Hello, everybody, and welcome back to MooseMed. I can't believe we're here. We're at the end of Neuro, so let's just get her done. All right, so we're going to start out with our paranasal sinuses, which are four paired air-filled spaces within the skull bones that are continuous with the nasal cavity. And although they are essentially just hollow spaces, they are lined with the same respiratory mucosa as the nasal cavity, meaning they participate in similar functions such as warming and humidifying inspired air. In addition to conditioning air, these sinuses reduce the overall weight of the skull. Think of them as like built-in air pockets that make the head less dense. And they contribute to resonance in the voice, which is why your voice sounds different when your sinuses are congested. There are four paired sinuses you need to know: the frontal sinus, which is located in the frontal bone above the orbits; the ethmoid sinuses, which are unique because they are not one large cavity, but instead consist of multiple small air cells within the ethmoid bone, positioned between the eyes. And then you have the maxillary sinus, which are the largest group of sinuses, and they sit within the maxilla. And clinically, these are the most commonly infected, largely due to their drainage pattern, which makes them prone to mucus retention. And then finally, you have the sphenoid sinuses, which are located deep within the sphenoid bone, near critical neurovascular structure like the optic chiasm and pituitary gland, which become important in surgical and pathological contexts. A key development point is that these sinuses form postnatally, meaning they are not fully developed at birth and continue to expand as the skull grows. The mucosa lining these sinuses is innervated by the trigeminal nerve, or cranial nerve 5, which carries general sensory information like pain. And this is why sinusitis, an inflammation of the sinuses, produces well-localized facial pain, often corresponding to specific sinuses involved. And finally, all of these sinuses drain mucus into the nasal cavity. And when this drainage is obstructed, it creates a setup for infection, pressure buildup, and the classic symptoms of sinusitis that you'll see clinically. Okay, so this slide breaks down the structural boundaries of the nasal cavity, which is a critical concept because it helps you orient where airflow travels and where pathology can occur. So starting externally, the apex and ala of the nose are composed entirely of cartilage, which provide flexibility and shape. And in contrast, the nasal bones form the dorsum, or the bridge of the nose. And then you have the nares, which are simply just the nostrils, the anterior opening that allow air to enter the nasal cavity. Moving internally, the roof of the nasal cavity is formed by the cribriform plate of the ethmoidal bone, and this is a thin perforated structure that allows olfactory nerve fibers, cranial nerve 1, to pass from the nasal mucosa into the olfactory bulb, and this makes it both functionally important for smell and clinically vulnerable. Fractures here can lead to cerebrospinal fluid leaks or anosmia, which is the loss of smell. The lateral wall of the nasal cavity is more complex and is composed of multiple bones, including the ethmoid bone, which forms the superior and middle nasal concha, the maxilla, lacrimal bone, inferior nasal concha, and palatine bone. The concha, also called turbinates, are curved bony shelves that increase surface area and create turbulent flow. And this turbulence improves warming, humidification, and filtration of the air, tying back to respiratory functions that you saw with the sinuses. The medial wall is the nasal septum, which divides the nasal cavity into right and left halves. It is formed by the vomer and the perpendicular plate of the ethmoid bone, in addition to it's anteriorly contributed by the septal cartilage, okay? So clinically, deviations of the septum are common and can obstruct airflow or impair sinus drainage, contributing to chronic sinus issues. The floor of the nasal cavity is formed by the maxilla and palatine bones, which also make up the hard palate. And this is an important relationship because it separates the nasal cavity from the oral cavity below. And deficits here, like a cleft palate, can disrupt both breathing and feeding. The anterior wall is formed by the nasal bones, reinforcing that entrance region that we discussed at the beginning of the slide. And while posteriorly the nasal cavity opens into the nasopharynx through the choanae, these posterior openings are the pathway through which air passes from the nasal cavity into the pharynx and eventually towards the lower respiratory tract. This connection becomes clinically relevant when considering airway obstruction, infections, or the spread of disease between nasal and pharyngeal regions. All right, so this slide focuses on nasal sinus drainage, which is one of the most clinically important concepts in head and neck anatomy because it explains why certain sinuses are more prone to infection than others. And so all of the paranasal sinuses ultimately drain into the nasal cavity, like we said, but the specific pathways they take and where they empty determine how easily mucus can clear. So when these pathways are blocked, mucus accumulates, creating an environment for bacterial growth and leading to sinusitis. So starting with the sphenoid sinus, it drains into the sphenoethmoidal recess, which is located superior and posterior to the nasal cavity above the superior nasal concha. This is a relatively isolated drainage pathway compared to the others, but its deep location near critical structures like the pituitary gland make pathology here clinically significant, especially in surgical approaches like transsphenoidal surgery. So the frontal sinus drains via the frontonasal duct into the anterior portion of the semilunar hiatus, or hiatus semilunaris, which is part of the middle nasal meatus. The semilunar hiatus is a curved groove that serves as a major drainage hub, and this connection is important because obstruction here can affect multiple sinuses simultaneously, not just the frontal sinus. The maxillary sinus, which is the largest sinus, also drains into the semilunar hiatus of the middle nasal meatus. However, its drainage opening is located relatively high on the medial wall, which means mucus has to move upward against gravity to exit. And this is a design flaw from a clinical perspective and explains why the maxillary sinus is most frequently infected, because you're basically keeping a little hot tub of mucus that bacteria are like, oh, this is great down here because it's never going to get drained because it's just a little inefficient, especially when it gets inflamed. So the ethmoid sinuses are divided into anterior, middle, and posterior air cells, and they drain into 3 different locations. The anterior ethmoidal cells drain into the semilunar hiatus, again, tying into that shared drainage pathway. And you can remember what drains from that semilunar hiatus based on the mnemonic FAM. So F for frontal nasal sinus, A for anterior ethmoidal air cells, and M for maxillary sinus. And so the middle ethmoidal cells drain the middle ethmoidal cells are going to drain onto the ethmoidal bulla, a bulge in the middle nasal meatus, and the posterior ethmoidal cells drain into the superior nasal meatus. And this distribution means ethmoid infections can present with more variable symptoms depending on which group is involved. And finally, the nasolacrimal duct, which carries tears from the lacrimal sac, and it drains into the inferior nasal meatus. And this explains why your nose runs when you cry, and so excess tears pass through this duct into the nasal cavity. And so putting this all together, the middle nasal meatus, especially the semilunar hiatus, is the key drainage crossroads here. So if that region becomes obstructed due to inflammation, polyps, or anatomical variation, it can impair drainage from the frontal, maxillary, and anterior ethmoid sinuses all at once, making it a central player in the development of sinusitis. All right, so this slide is going to be covering all the blood supply to the nasal cavity and paranasal sinuses, and the key idea here is that the region has a dual arterial supply coming from both the internal carotid artery and the external carotid artery. And this is clinically important because it creates areas of rich vascular anastomosis, which explains why nosebleeds are so common and sometimes difficult to control. So from the internal carotid artery, specifically via the ophthalmic artery, you get the anterior and posterior ethmoidal arteries. These vessels primarily supply the superior portions of the nasal cavity, including the ethmoid sinuses and parts of the septum. Because they originate from the ophthalmic circulation, they also connect this region to the orbit, which becomes relevant when considering the spread of infection or surgical risk. From the external carotid artery, the main contributors are the facial artery and the maxillary artery. And the facial artery gives rise to branches like the superior labial artery, which contributes to the anterior nasal septum. The maxillary artery is especially important because it gives off the sphenopalatine artery, often considered the primary arterial supply to the nasal cavity, as well as the greater palatine artery. And these branches supply deeper and posterior regions of the nasal cavity and septum. All of these vessels come together in a clinically significant region called the Kisselbox area, also known as Little's area, and this is located on the anterior nasal septum. And this is a vascular plexus formed by contributions from the facial artery, anterior ethmoidal artery, greater palatine artery, and sphenopalatine artery. And because this area is superficial and highly vascular, it is a very common site of anterior epistaxis or nosebleeds. So the good news clinically is that because it's accessible, bleeding here is usually easy to control with direct pressure. And so finally, focusing on the maxillary artery, its key branches in this context are the sphenopalatine artery and the greater palatine artery. The sphenopalatine artery enters the nasal cavity through the sphenopalatine foramen and supplies much of the posterior nasal cavity, while the greater palatine artery descends from the palate to contribute to the septum. So understanding these branches is especially important in severe or posterior nosebleeds where surgical ligation of the sphenopalatine artery may be required. All right, and so this slide covers the innervation of the nasal cavity, and a key framework to keep in mind is that the 3 different cranial nerves contribute, each with a distinct functional role. So together they handle smell, general sensation, and autonomic control of mucus and blood flow. First is cranial nerve 1, the olfactory nerve, which carries special visceral afferent fibers responsible for the smell. These are bipolar neurons located in the olfactory epithelium of the nasal cavity. Their axons pass superiorly through the cribriform plate of the ethmoid bone and synapse in the olfactory bulb. And this is a direct connection to the brain, so it's unique compared to the other sensory systems and explains why damage to the cribriform plate, such as a skull base fracture, can lead to anosmia or loss of smell. Next is cranial nerve V1, the ophthalmic division of trigeminal nerve, which provides general somatic afferent sensation to superior portion of the nasal cavity. And this includes things like touch, pain, and temperature from the upper nasal septum and lateral wall. And these fibers travel primarily via the anterior ethmoidal nerve, a branch of the ophthalmic nerve, linking the nasal cavity to the orbit and anterior cranial fossa. Cranial nerve V2, the maxillary division of trigeminal nerve, provides GSA sensation to the inferior portion of the nasal cavity, and this is where a lot of clinically relevant details come in. So branches of V2 pass through the pterygopalatine ganglion region and distribute widely. The nasopalatine nerve is particularly high yield because it travels along the nasal septum and continues through the incisive canal to the anterior palate, carrying sensation from both regions. And because of this pathway, dental or palatal pain can sometimes be referred to the nasal septum and vice versa. In addition to general sensation, V2 also serves as a major distribution pathway for autonomic fibers. So parasympathetic fibers, which originate from the facial nerve via the greater petrosal nerve, synapse in the pterygopalatine ganglion, and then hitchhike along V2 branches to reach the nasal mucosa. And these fibers stimulate mucus secretion. Sympathetic fibers coming from the superior cervical ganglion regulate vasoconstriction in nasal blood vessels, and so together, these autonomic inputs control congestion, secretion, and overall nasal physiology, which becomes highly relevant in conditions like allergic rhinitis or chronic sinusitis. All right, so this slide introduces the 3 regions of the ear and organizes them by both structure and function, which is the key way to think about hearing and balance as a stepwise process. So the external ear consists of the auricle, also known as the pinna, and the external acoustic meatus, or EAM. The auricle is a visible portion of the ear made of cartilage, and its shape helps funnel sound waves into the external acoustic meatus. The EAM is the canal that directs those sound waves towards the tympanic membrane or the eardrum. And the primary function of the external ear is to collect and channel sound efficiently toward the deeper structures. And this is the first step in hearing, purely mechanical capture and direction of sound energy. The middle ear is an air-filled cavity called the tympanic cavity that contains the auditory ossicles, the malleus, incus, and stapes, as well as the auditory tube, also called the pharyngotympanic or eustachian tube. The tympanic membrane vibrates in response to incoming sound waves, and those vibrations are transmitted through the ossicles. The malleus attaches to the tympanic membrane, the incus acts like a little bridge, and then the stapes connects to the oval window of the inner ear. The key function of the middle ear is just amplification. So because sound waves are moving from air into fluid in the inner ear, there would normally be significant energy loss. But the ossicular chain increases the pressure of the signal to overcome this impedance mismatch. And so the auditory tube connects the middle ear to the nasopharynx and equalizes this pressure. So dysfunction here is why you feel a fullness during altitude changes, or why children are prone to middle ear infections known as otitis media. The inner ear contains the cochlea and vestibular system, which includes structures like the semicircular canals, and this region is responsible for transduction, meaning it converts mechanical energy into neural signals. In the cochlea, sound vibrations are transformed into electrical signals by hair cells and then transmitted via the cochlear branch of cranial nerve 8, the vestibulocochlear nerve. The vestibular system, on the other hand, detects head movements and position, contributing to balance and spatial orientation. And the vestibular branch of cranial nerve 8 carries this information to the brain. Together, the inner ear handles both hearing and equilibrium, making it essential not just for sensing sound, but also for maintaining posture and coordinated movement. Okay, and this slide just focuses on the detailed anatomy of the auricle and external acoustic meatus, which together make up the external ear and serve as the entry point for sound into the auditory system. So starting with the auricle, again, this structure is composed of elastic cartilage, which gives it flexibility and allows it to maintain its shape. The key exception is the lobule, or earlobe, which contains no cartilage and is instead made of soft connective tissue and fat. And this explains why the lobule tends to bleed more when injured, but also heals relatively well due to its vascularity. The auricle has several named landmarks that are both anatomically and clinically relevant. The helix forms the outer rim of the ear, while the antihelix lies just inside it as a raised ridge. The tragus is a small projection that partially covers the opening of the external acoustic meatus, helping to protect the canal. And then the concha is the deepest bowl-shaped portion of the auricle, and it plays a key role in funneling sound into the ear canal, acting as a natural amplifier and director of incoming sound waves. Moving into the external acoustic meatus, this is the canal that carries sound from the auricle to that tympanic membrane, and it is continuous with the tympanic membrane, meaning it directly leads to the eardrum, where sound waves are converted into mechanical vibrations. Structurally, the external acoustic meatus is divided into two distinct portions. The lateral 1/3 is made up of cartilage and continuous with cerium glands, which produce earwax, and cerium serves protective functions, like it traps debris, repels water, and has antimicrobial properties. The medial 2/3, in contrast, is bony and lacks glands, making it sensitive and more susceptible to injury during procedures like an ear cleaning. The canal terminates at the tympanic membrane, which separates the external ear from the middle ear. And this membrane is critical for hearing because it vibrates in response to sound waves and transmits those vibrations to the ossicles of the middle ear. Clinically understanding the transition from cartilage to bone in the external acoustic meatus is important, as the bony portion is more painful when manipulated, and infections like otitis externa, commonly known as swimmer's ear, often involve the skin lining the canal. All right, so this slide covers the blood supply and innervation of the external ear, and the key theme here is that both vascular and nerve supply are highly distributed, which explains the ear's sensitivity and its clinical behavior with trauma and pain referral. So starting with arterial supply, the external ear receives blood primarily from branches of the external carotid artery. The posterior auricle artery supplies the posterior aspect of the auricle, or ear. So while the superficial temporal artery contributes to the anterior and superior regions. The deep auricle artery, which is a branch of the maxillary artery, supplies the deeper structures of the external acoustic meatus. So venous drainage generally follows the exact same pattern as the arteries through venae comitantes, meaning veins run along the arteries and drain into larger venous systems. Okay, so a key clinical correlation here is that trauma to the auricle, which can lead to auricular hematoma. This occurs when blood collects between the perichondrium and the cartilage, disrupting the blood supply to the cartilage itself. And because cartilage relies on the perichondrium for nutrients, this can lead to cartilage necrosis and subsequent deformity known as cauliflower ear, commonly seen in wrestlers and boxers. Prompt drainage is necessary to prevent permanent damage. The innervation of the auricle is complex and comes from multiple sources, but you have the great auricular nerve, arising from cervical spinal nerves C2 and C3, and this supplies much of the inferior and posterior auricle. The auriculotemporal nerve, a branch of the mandibular division of trigeminal nerve, or CNV3, supplies the anterior portion, including the tragus and nearby areas. The lesser occipital nerve, also from C2 and C3, contributes to the superior posterior region. Additionally, the vagus nerve, cranial nerve 10, provides sensory input via its auricular branch, and there is a small contribution from the facial nerve, cranial nerve 7. For the external acoustic meatus specifically, innervation is primarily from the auriculotemporal nerve, V3, and the auricle branch of vagus nerve, cranial nerve 10. And I only said V3 after auriculotemporal nerve because it's a branch of that mandibular branch of trigeminal nerve, okay? The involvement of the vagus nerve is clinically important because stimulation of the ear canal can trigger a reflex cough known as Arnold's reflex, and this is a classic example of how sensory input in one region can produce a reflex response somewhere else due to just shared neural pathways. So overall, the combination of multiple arterial sources and overlapping nerve supply makes the external ear both resilient and also highly sensitive. So while also this explains its unique clinical presentations in trauma like infection and the weird referred pain. And so this slide just covers the lymphatic drainage of the external ear, and the key idea is that different parts of the auricle and external acoustic meatus are just going to drain into different lymphatic groups, right? So the lateral portion of the auricle primarily drains into the parotid lymph nodes, which are located around the parotid gland just anterior to the ear. And this means that lesions or infections on the outer visible surface of the ear often present with swelling in this pre-auricular or parotid region. The superior and posterior parts of the auricle, as well as portions of the external acoustic meatus, drain into the mastoid lymph nodes, also called the posterior auricular lymph nodes. And then after that, they drain to the deep cervical lymph nodes. Because remember, all lymph is going to be draining from superficial to deep. The deep cervical chain then runs along the internal jugular vein and is a major drainage pathway for much of the head and neck. And because of this, more significant or spreading infections in the ear can ultimately present with deep cervical lymphadenopathy. The lobule, which is the inferior non-cartilaginous portion of the ear, right, where we all get our ears pierced, and that's going to drain to the superficial cervical lymph nodes. And these nodes lie along the external jugular vein as well and are more superficial compared to those deep cervical chain ones. And clinically, this means that swelling in the lower ear region may be associated with palpable superficial nodes along the lateral neck. So overall, lymphatic drainage of the external ear follows a predictable pattern just based on the regions, and understanding these pathways will just help you localize the source of infection or disease when you're evaluating lymph node enlargements. And so this slide introduces the middle ear, specifically the tympanic cavity, and the key idea is that, again, it's that air-filled mucosa-lined space that serves as a mechanical bridge between the external ear and the inner ear. And the mucosal lining, again, is continuous with that nasopharynx via the auditory and pharyngotympanic tube, which is why infections of the upper respiratory tract spread to that middle ear. And so the tympanic cavity is not an isolated space. It is connected posteriorly to the mastoid air cells and anteriorly to the nasopharynx through that auditory tube. The mastoid air cells act like an extension of the middle ear, and clinically, infections of the middle ear can spread into these cells, leading to mastoiditis. The connection to the nasopharynx is functionally important because it allows pressure equalization across the tympanic membrane. So when this tube is blocked, such as during a cold or in children with shorter, more horizontal tubes, pressure cannot equalize properly, leading to discomfort or increased risk of otitis media or middle ear infection. Within the tympanic cavity are several key structures, the auditory ossicles like the malleus, incus, and stapes, which form a chain that transmits and amplifies sound vibrations from the tympanic membrane to the oval window of the inner ear, and two small muscles, the tensor tympani and stapedius, stapedius, and these attach to the ossicles and function to dampen excessive movements. So this protective mechanism helps reduce damage from loud sounds, and dysfunction of stapedius muscle, such as facial nerve palsy, can lead to hyperacusis, which is where sound is perceived as abnormally loud. The tympanic plexus is a network of nerves located on the promontory of the middle ear that provides sensory innervation to the mucosa. It is primarily formed by contributions from the glossopharyngeal nerve, cranial nerve 9. Also passing through the middle ear is chorda tympani, a branch of facial nerve, cranial nerve 7, and this nerve carries taste fibers from the anterior two-thirds of the tongue and parasympathetic fibers to salivary glands, and it runs across the tympanic cavity in close association with the ossicles. And because of its location, it is vulnerable during middle ear infections or surgical procedures, which can lead to altered taste sensation or decreased salivation. All right, and this slide outlines the boundaries of the middle ear, specifically the tympanic cavity, and this is a high-yield spatial map because it tells you exactly what critical structures are sitting adjacent to the middle ear. And clinically, this is why infections here spread in very dangerous ways. So starting superiorly, the roof of the middle ear is formed by tegmen tympani, a thin plate of temporal bone. Directly above this lies the middle cranial fossa and the temporal lobe of the brain. Because this bone is so thin, severe middle ear infections can erode through it and lead to intracranial complications like meningitis or brain abscesses. Inferiorly, the floor of the middle ear is also a thin bony plate, and anteriorly, it overlies the carotid canal, which is continuous with the internal carotid artery, and posteriorly, it sits above the jugular fossa, which houses the internal jugular vein. This means that vascular structures are immediately below the middle ear, so erosion or congenital abnormalities can basically expose these vessels, posing risks during infections or surgery. Laterally, the boundary is the tympanic membrane, which separates the middle ear from the external acoustic meatus. And this is that structure you visualize during otoscopic exams, and it serves as the entry point for sound transmission to that middle ear. We covered it in the last slide, right? Medially, the wall is called the labyrinthine wall, and this is where things get functionally important. It contains the promontory, which is formed by the basal turn of the cochlea, as well as the oval window and round window. The stapes foot plate sits in the oval window, transmitting vibrations into the inner ear, while the round window allows for pressure release within the fluid-filled cochlea, and damage here directly affects hearing. Posteriorly, the middle ear communicates with the mastoid air cells via the mastoid antrum, and this wall also contains the canal for facial nerve, cranial nerve 7. And this is clinically significant because those middle ear infections or inflammation can affect facial nerve, leading to facial weakness or paralysis. Anteriorly, the middle ear opens into the auditory or pharyngotympanic tube, which connects the nasopharynx and helps equalize that pressure like we talked about. And this wall also contains the semicanal for tensor tympani muscles. And because of this connection, infections from the upper respiratory tract, again, can travel into that middle ear, especially in children. So overall, again, that middle ear sits in a very tight anatomical neighborhood. You got the brain above, you have the major vessels below, inner ear medially, and cranial nerves running through it. So knowing these boundaries are pretty essential for predicting the symptoms. All right, so this slide is just going to focus on the tympanic membrane or eardrum, which is a critical structure because it serves as the interface between the external ear and, again, that middle ear. And it's responsible for initiating the process of hearing. So the tympanic membrane is composed of 3 distinct layers, each with a different origin and function. The outer layer is skin, which is continuous with the skin of the external acoustic meatus. And then you have the middle layer, which is fibrous. And this is providing structural integrity and tension that allows the membrane to vibrate effectively. The inner layer is mucosa, and it's continuous with the lining of the middle ear. And this layered structure reflects its role as both a barrier and a mechanical transducer. Several key anatomical features are important for orientation during an otoscopic exam. So the cone of light is a reflection seen on the tympanic membrane and it normally points in an anterior and inferior direction toward the nose. And this is a quick way clinicians like to assess whether the membrane is in a normal position. If the cone of light is distorted or absent, it can indicate a pathology such as fluid buildup or inflammation of the middle ear. The malleus, one of the auditory ossicles, is attached to the tympanic membrane, specifically along its handle, which is visible through the membrane during examination, and this attachment allows vibrations of that tympanic membrane to directly be transmitted to the ossicular chain. And so that central point where the malleus pulls inward is called the umbo, kind of like elbow. All right, so this slide is going to just be focusing on that blood supply and innervation of the tympanic membrane, and the key concept is that the eardrum has dual-sided organization. Its external surface behaves like skin, while the internal surface behaves like mucosa, and each side has a distinct nerve and vascular supply. Starting with arterial supply, the primary vessel is the anterior tympanic artery, which arises from the first part of the maxillary artery, a branch of the external carotid artery, and this artery supplies much of the tympanic membrane, particularly its external surface. Because this vessel comes from the maxillary system, it ties the tympanic membrane into the broader vascular network of the deep face. Venous drainage of the tympanic membrane is more complex and connects to a larger venous pathway. Blood drains into the transverse and posterior petrosal sinuses, which are intracranial venous channels, as well as the pterygoid venous plexus, a network of veins located in that infratemporal fossa. And this connection between superficial structures and deeper venous systems is clinically relevant because it provides potential routes for the spread of infection. The sensory innervation is divided based on 2 surfaces of the membrane. So the external surface is innervated by the auriculotemporal nerve, a branch of the mandibular division of trigeminal nerve, or cranial nerve 5-3 or V3, and also receives input from the auricular branch of vagus nerve, cranial nerve 10. And this overlap explains why stimulation of the ear canal or tympanic membrane can trigger reflexes like coughing, again due to that vagus nerve involvement. So the internal surface of the tympanic membrane is innervated by the tympanic branch of the glossopharyngeal nerve, cranial nerve 9, and this branch contributes to the tympanic plexus within the middle ear and provides sensory innervation to the mucosal side of the membrane. Putting this together, the tympanic membrane sits at neurological crossroads where trigeminal, vagus, and glossopharyngeal inputs all converge, and this explains why that ear pain can sometimes be referred from other regions innervated by these nerves, such as the throat, the jaw, and why pathology affecting middle ear can present with a diverse set of sensory symptoms. All right, so this slide is covering that pharyngotympanic tube, also known as the eustachian tube, or the auditory canal, and this is the key idea. It's that the structure is, again, connecting that middle ear to the nasopharynx, and it plays a critical role in that pressure regulation. So anatomically, the tube runs from the tympanic cavity to the nasopharynx and is composed of two different materials. The lateral 1/3 is bony, while the medial 2/3 is cartilaginous. The distinction matters because the cartilaginous portion is flexible and capable of opening and closing, whereas the bony portion is rigid. At rest, the tube is normally closed, which helps protect the middle ear from pathogens and pressure fluctuations coming from the nasopharynx. And functionally, the primary role of the pharyngotympanic tube, again, is to equalize that pressure between the middle ear and the external environment. And this is essential for proper movement for the tympanic membrane. If pressure is not equalized, the membrane cannot vibrate efficiently, leading to a sensation of fullness or decreased hearing. And this is what you experience during altitude changes, like an airplane, when your ears go pop. So the tube opens during activities like swallowing, yawning, or chewing, and this opening is mediated by two muscles, the tensor veli palatini and levator veli palatini. The tensor veli palatini is the primary muscle responsible for actively opening this tube, while levator veli palatini acts by elevating the soft palate and contributing to an opening mechanism. So the muscles link the ear to the function of the palate, which is why simple actions like swallowing can restore pressure balances. Clinically, the structure is specifically important to children. In kids, the pharyngotympanic tube is shorter and it's wider and more horizontally oriented compared to adults, so this makes it easier for pathogens from the nasopharynx to travel into the middle ear, leading to a higher incidence of otitis media or middle ear infections, and it also makes drainage way less efficient, further contributing to buildup and infection risk. All right, so now we're just going to focus on those auditory ossicles, which form the sound amplification of the chain of the middle ear. And the key idea is that these tiny bones basically convert relatively weak air vibrations into a stronger mechanical force capable of moving fluid in the inner ear. So the ossicular chain consists of three bones arranged in a sequence. We have the malleus, the incus, and the stapes. And the malleus is attached directly to the tympanic membrane. So when the eardrum vibrates in response to sound waves, the malleus moves with it. The malleus transmits that motion to the incus, which acts like an intermediate link, and finally to the stapes. And so the stapes is unique because its footplate sits within the oval window, which is the entrance to the inner ear. And so functionally, the chain amplifies vibrations, and the amplification is necessary because sound waves are transitioning from air in the external and middle ear to fluid in the cochlea of the inner ear. And so without this amplification, much of that sound energy would be lost due to impedance mismatch between air and fluid. A little shout out to physics in undergrad. And then the ossicles overcome this by basically just increasing the force of that vibration while decreasing its amplitude, and effectively concentrating this energy onto a much smaller surface area of the stapes footplate. When the stapes footplate moves at the oval window, it creates a pressure wave in the fluid of the inner ear, irritating movement within the cochlea. And so the fluid movement is what ultimately leads to the activation of hair cells and conversion into neural signals. So clinically, disruption of this chain, such as fixation of the stapes in conditions like otosclerosis, leads to conductive hearing loss. And because sound cannot be efficiently transmitted into the inner ear, similarly, damage to any part of the ossicular chain will just in general reduce amplification and will thus impair hearing. And the way I kind of like to remember the order in which these go is that malleus, right? It's attached to that tympanic membrane, and malleate sounds like mallet, so it makes sense that it's the guy to initially start the amplification because you're banging down on the other bones. And then I remember the third one, which is stapes, because it sounds like staple, and when you staple something, a staple is flat on a piece of paper, so it's at the very bottom. And I just remember that incus is in the middle. It might just be a first order question, who knows, but that's just my little mind map to remember the order. And so this slide covers the middle ear muscles, which are small but functionally critical because they regulate how much sound energy is transmitted through the ossicular chain, essentially acting as that protective system against excessive vibration that we talked about. So tensor tympani muscle attaches to the malleus itself, and it is innervated by the mandibular division of trigeminal nerve, specifically cranial nerve V3, which is consistent with embryological origin from that first pharyngeal arch. Embryology is never going away, guys. It's everywhere, and it will for sure be on your neuro exam. They love the arches, so please go back to that first video and review the pharyngeal arches because they will be making a comeback for sure. When this muscle contracts, it basically pulls the malleus medially, increasing tension on the tympanic membrane. And this action dampens vibrations of the tympanic membrane, particularly in response to self-generated sounds like chewing or speaking, preventing overstimulation of the auditory system. The stapes muscle, on the other hand, inserts itself onto the stapes and is innervated by the facial nerve, cranial nerve 7, reflecting its origin from the second pharyngeal arch. And when stapes contracts, it stabilizes the stapes at the oval window, reducing the amplitude of its movement. And this is especially important for dampening loud external sounds, and it forms part of the acoustic reflex, a protective mechanism that reduces the transmission of potentially damaging high-intensity noise to the inner ear. So clinically, the stapes is more important of the two muscles to remember, because if there is a lesion of the facial nerve, such as Bell's palsy, the stapes becomes paralyzed, and without that dampening effect, the stapes moves excessively in response to sound, leading to hyperacusis, where normal sounds are basically perceived as abnormally loud and uncomfortable. And this symptom can help localize lesions affecting that facial nerve within the temporal bone. All right, so this slide is just going to be covering the nerves of the middle ear. And the key concept, again, is that this is a small space that contains multiple important neural pathways that carry sensory information and parasympathetic fibers, making it a clinically sensitive area where pathology can produce diverse symptoms. So the tympanic plexus is a primary nerve network within the middle ear, and it is formed mainly by the tympanic branch of the glossopharyngeal nerve, cranial nerve 9, along with sympathetic fibers from the carotid plexus. And this plexus sits on the promontory of the medial wall of the middle ear and provides general sensory innervation to the mucosa of the tympanic cavity. And because of this, inflammation or infection of the middle ear can produce pain that is referred along cranial nerve 9 pathways, sometimes felt in the throat. From the tympanic plexus arises the lesser petrosal nerve, which carries preganglionic parasympathetic fibers, and these fibers eventually synapse in the otic ganglion and then travel to the parotid gland, where they stimulate saliva production. And this creates a functional link between the middle ear and salivary secretion, so even though the final target is outside of the ear itself. And so another critical structure passing through the middle ear here is chorda tympani, and it's a branch of the facial nerve, cranial nerve 7. And this nerve runs across the tympanic cavity between the ossicles, making it particularly vulnerable to damage, and it carries taste sensation from the anterior 2/3 of the tongue, and also carries those parasympathetic fibers for the submandibular and sublingual glands, which are responsible for saliva production in the floor of the mouth. Clinically, this arrangement explains why middle ear disease can affect taste. If the chorda tympani is damaged by infection, inflammation, or surgical intervention, patients may experience a loss or alteration of taste in the anterior 2/3 of the tongue, along with reduced salivation. So this is a high yield association because it's, again, linking that inner ear pathology to oral sensory changes, which might otherwise seem unrelated. All right, and this slide just gives us a high level overview of the inner ear, and the key framework is that there are two parallel systems. You have the bony labyrinth, which is filled with paralymph, and then you have the membranous labyrinth, which is filled with endolymph, and each contains a structure responsible for hearing and balance. So the bony labyrinth is a rigid outer casing with the temporal bone and contains perilymph, a fluid similar to extracellular fluid, and within this system, the cochlea is responsible for hearing. It converts mechanical vibrations into neural signals, and the vestibule, which sits centrally, is involved in detecting linear acceleration and head position relative to gravity. So then we also have the semicircular canals, which are oriented in 3 planes and detect rotational or angular movements of the head. And together, these structures allow the body to basically both perceive sound and spatial orientation. Nested within the bony labyrinth is the membranous labyrinth, which contains endolymph. And I just remember the membranous labyrinth is deeper, and if it's deeper, it's going to have something called endo in it, so endolymph, right? Endo within. And it's a fluid with a unique composition with high potassium. The ionic environment is critical for the function of sensory hair cells, which is within the membranous systems. you have the utricle and saccule, which are located in the vestibule and are responsible for detecting linear acceleration and head tilt. And so the semicircular ducts, which lie within the semicircular canals, detect rotational movement again through the displacement of endolymph, which bends hair cells in response to motion. Then you have the cochlear duct, also known as the scala media, and this is a portion of the membranous labyrinth involved in hearing, and it contains the organ of Corti, where the mechanical vibrations are converted into electrical signals that can be transmitted to the brain via cochlear branch or of cranial nerve 8, and that's going to be the vestibular cochlear nerve. So the distinction between perilymph and endolymph is essential because disruptions in endolymph dynamics, such as Meniere's disease, can lead to symptoms like vertigo, hearing loss, and tinnitus. And overall, the inner ear is where mechanical energy is finally translated into that neural information for both hearing and balance. And speaking of, here is synaptic transmission, which is basically that fundamental process neurons use to communicate, and the key idea that electrical signals are converted into chemical signals and then back into electrical activity in the next neuron. So the process begins with neurotransmitter synthesis inside the presynaptic neuron, and these neurotransmitters are then packaged and stored in synaptic vesicles, not vascular storage, which is a common wording mix-up. So make sure synaptic vesicles, right? And this is a vesicular storage, which within the nerve terminal. And when an action potential arrives at the presynaptic terminal, it triggers the opening of voltage-gated calcium channels. And calcium ions enter the cell, and the influx is a critical signal that causes synaptic vesicles to fuse with the membrane and release neurotransmitters into the synaptic cleft. And once released, the neurotransmitters diffuse across the synaptic cleft and bind to receptors on the postsynaptic membrane. And this receptor binding determines the type of response. So if the receptor is ionotropic, it directly forms an ion channel. And these receptors act quickly, producing rapid changes in the membrane potential, either depolarizing or hyperpolarizing the cell, and therefore directly affecting whether the neuron will fire an action potential. If the receptors are metabotropic, the effect is indirect, and these receptors are typically G-protein coupled receptors, or GPCRs, which activate intracellular signaling cascades. So instead of immediately changing ion flow, they modify cellular activity more slowly by altering ion channel behavior, gene expression, or metabolic processes. And this leads to longer lasting and modulatory effects on neural responsiveness rather than immediate firing. And so finally, neurotransmitter signaling must be determined to prevent continuous stimulation. So this occurs either through reuptake back into the presynaptic neuron, or enzymatic degradation in the synaptic cleft, or diffusion away from the synapse. So overall, voltage-gated calcium channels serve as that key link between electrical activity and chemical transmission, translating and arriving action potential into the neurotransmitter release, which then propagate the signal across neurons. So this slide summarizes the major neurotransmitters, and the key takeaway is just to think about it all like balance. And this is basically me just going to be prepping you because we're about to dive into a lot of pharmacology, and these are going to be our main players, okay? So basically a lot of psychiatric pathology comes from too much or too little of these guys, okay? And so it's never like an absolute presence or absence of them. It's just a balance issue. So let's start with glutamate. And this is going to be your primary excitatory neurotransmitter in the central nervous system. Its core function is just to increase neuronal firing, all right? When glutamate levels are increased, you get excessive excitation, which can lead to instability in neural circuits and ultimately seizures. When decreased, you see reduced excitation, leading to central nervous system depression and impaired cognition. A critical concept here is that excitotoxicity. Too much glutamate causes neuronal damage due to excessive calcium influx, which is a major mechanism in conditions like a stroke or traumatic brain injury. So I just like to think of glutamate as like the gas for your body. It's like bang, right? Everything's going. Then you have GABA, or gamma aminobutyric acid, and it is the main inhibitory neurotransmitter. It decreases neuronal firing and stabilizes neural circuits. So when GABA activity is increased, neuronal firing decreases, leading to sedation and anxiolysis, which is why many anti-anxiety or sedative drugs enhance GABA signaling. When GABA is decreased, inhibition is lost, leading to excessive excitation, which can manifest as seizures or anxiety. And so the key concept here is that inefficient inhibition creates instability in the nervous system, right? And GABA, I feel like GABA is pretty, we all know GABA, right? I mean, some people even give GABA to their pets to like chill them out on car rides. Then you have acetylcholine, which plays a major role in cognitive modulation, especially in attention, learning, and memory. Increasing acetylcholine can modestly improve cognition, which is why drugs that enhance acetylcholine are used in conditions like Alzheimer's disease. And however, too much can lead to confusion. So when acetylcholine is decreased, you see cognitive decline, memory impairment, and potentially delirium. And so the takeaway here is that acetylcholine requires a careful balance for optimal cognitive function. Then you have dopamine, which is an involved pathway. And so it basically affects, it depends on which neural pathway is involved here. So increased dopamine can lead to psychosis or dyskinesia, while decreased dopamine is associated with Parkinson's symptoms and reduced motivation. And this is why dopamine is such a central target in both movement disorders and psychiatric conditions. So the key concept is that dopamine effects are pathway dependent and involve trade-offs. So for example, treating psychosis can worsen movements and vice versa. Norepinephrine is responsible for arousal and attention. So increased levels enhance alertness, but excessive levels can lead to anxiety and impaired focus. And decreased norepinephrine leads to fatigue, decreased attention, and reduced arousal. So the important concept here is that inverted relationship, right? So there is an optimal level of norepinephrine for performance, and both too little and too much impair function. And then finally, you have serotonin, and it's a context-dependent modulator that affects mood, anxiety, sleep, and perception. Its effects are variable depending on receptor subtype and brain region, so increasing or decreasing serotonin does not produce a single predictable outcome, but this is why serotonergic drugs can have a wide range of effects. And so the key concept here is that serotonin does not have a simple directional effect like purely excitatory or inhibitory neurotransmitters. And so with acetylcholine, I like to remember it's involved with cognition and whatnot because Alzheimer's starts with A, acetylcholine starts with A. There you go. Dopamine, I just remember the psychosis Parkinson's thing, right? Too little dopamine, Parkinson's, too much, you're on dope, you go crazy. So dopamine. Norepinephrine, I like to think of it in a really dumb way, like that one H2O just add water, that Australian show about mermaids, how they all say no all funny, like the Claire, those Australian actresses. If you don't know what I'm talking about, I'm extremely sorry. But with norepinephrine, I like to remember it's attention and arousal because it's like someone saying no in an Australian accent. You go, nor, oh my god, like kind of very playfully. So arousal, attention, there you go. I just like to remember it like that. Pretty dumb. And then serotonin, like I said, wide range of effects, but this is most likely going to be applied to SSRIs, which we'll get into later. But I just remember that this makes you happy with like the big takeaway thing there. But there you go. So now let's get into some drugs. Okay, I actually lied. One more slide before we get into the drugs, right? I really want to hammer this home because pharmacology can get really complicated if you don't just dumb it down first. So again, this slide just is going to set up how to think about central nervous system drugs. And the core idea is that most of them don't turn things on or off. It's just a shift of balance between excitation and inhibition in neural circuits. So at baseline, the brain is constantly balancing excitatory signals, largely driven by glutamate, right? Our gas pedal. And so with inhibitory signals, primarily mediated by GABA, right? So CNS drugs work by tipping this balance. So one strategy is either increasing inhibition, typically through GABAergic drugs, and these are just enhancing GABA signaling, leading to decreased neuronal firing, which is why they're used for sedation, anxiety, and seizure control. And the other strategy is decreasing excitation, often by modulating glutamate pathways, which also reduces overall neural activity and can stabilize overactive circuits. Where things become more complicated is in the pharmacology. So first, most drugs, or the drugs that we use for the central nervous system have to be able to cross that blood-brain barrier, or BBB, which is a highly selective barrier that limits what substances can enter the brain. And this means that CNS drugs often need specific properties, like lipid solubility, to be effective. Second, Altering one pathway rarely just affects one function, right? Drugs are complicated. So neural systems are highly interconnected. So change activity in one neurotransmitter system can have downstream effects across multiple circuits. So for example, modifying dopamine can affect movement, mood, and cognition all at once, right? That balance of psychiatric issues with movement issues that we talked about. Finally, many central nervous system drugs are not highly specific. They often act at multiple receptor sites and influence multiple neurotransmitter systems simultaneously. And this is why side effects are so common and why predicting drug effects can be challenging. A medication intended to reduce anxiety might also cause sedation, cognitive slowing, or motor effects because it was influencing several overlapping neural pathways. Overall, the takeaway is that CNS pharmacology is more about, again, just shifting that balance, not targeting isolated pathways, which is what makes both its therapeutic effects and side effects a little complex. All right, and now we're going to basically break up these drugs by the systems that they act on. So we're getting into glutamate and GABA systems, and the key framework here, again, is that these medications are either going to reduce excitation by blocking glutamate pathways or increase inhibition by enhancing GABA activity. So starting with glutamate, the main excitatory neurotransmitter, the focus here is on NMDA receptors, which are a subtype of glutamate receptor involved in synaptic plasticity, learning, and excitotoxicity. Ketamine is an NMDA receptor antagonist, meaning it's going to block excitatory signals through this receptor. However, its effects is not just as simple as CNS depression. It alters the organization of consciousness and it produces dissociative anesthesia. So patients may appear awake but are disconnected from their environment, which is why ketamine is used in certain procedural settings and also being explored for treatment-resistant depression. I like to remember ketamine is the one that still allows you to be somewhat conscious, right? Because actually a lot of cocaine addicts take ketamine to balance out the excitatory effects of cocaine. And the only reason I knew that is because I did a lot of theater in high school and I had to memorize this one monologue where it was basically like this brother going on a rant about drugs and he was basically just describing how he cut his cocaine. So that one's easy for me to remember, and hopefully that maybe transfers on to you. But if you just remember that ketamine, opposite of cocaine, so you could still be awake and having a party, but you're not completely sedated. Yeah, that's kind of how I remember ketamine. Memantine is another NMDA receptor antagonist, and I remember it as a less fun ketamine because you're still going to be conscious. It's just going to give you mild confusion and dizziness, and this one's often used in Alzheimer's disease to reduce excitotoxicity and a slow cognitive decline. So the idea here is that excessive glutamate activity contributes to that neuronal damage over time, and so to maintain that, memantine basically dampens this without shutting down normal signaling. Okay. Then switching to GABA, the primary inhibitory neurotransmitter, these drugs enhance inhibitory tone and decrease neuronal firing. So we have diazepam and benzodiazepine, and this is going to increase the frequency of chloride channels opening at GABA A receptors. So this leads to a hyperpolarization of neurons, making it harder for them to fire action potentials. And clinically, this is why diazepam is effective for seizure control, anxiety, and sedation. Then we have phenobarbital. A barbiturate also acts on GABA A receptors, but increases the duration of chloride channels opening rather than the frequency. So diazepam increases the frequency, phenobarbital increases the duration. Okay. So this procedure is stronger and more prolonged inhibitory effect, which is why it is used for sedation and seizure control. However, this also comes with a higher risk of overdose and significant central nervous system depression, including respiratory depression. And then finally you have propofol, and it's a potent GABA A receptor potentiator used for induction of anesthesia, and it produces profound central nervous system suppression very rapidly, which is why it's widely used in operating rooms, and its effects are powerful and fast-acting, but they require careful monitoring because of the risk of respiratory depression and cardiovascular effects. I remember propofol for kind of a morbid reason, but this was actually what killed Michael Jackson. He was literally taking propofol as melatonin. This bro would take this before bed every day. But it was this in combination with other barbiturates that unfortunately ended up taking his life. But propofol is the big one. So that's how I remember propofol is the strongest one because it took MJ. And then so overall, right, glutamate targeting drugs reduce excitatory signaling while GABAergic drugs enhance inhibition. The balance between these two systems is what determines overall neuronal activity, and these medications shift that balance in controlled ways to achieve therapeutic effects. So this slide focuses on acetylcholine-related drugs, and the key idea here is that these medications either increase acetylcholine signaling to support cognition or decrease it to suppress certain pathways with very different clinical effects. So donepezil works by inhibiting acetylcholinesterase, and again, this is, that little suffix there, esterase, right? So this enzyme is going to be breaking down acetylcholine in the synaptic cleft. And so by blocking this enzyme, acetylcholine levels increase, allowing for stronger and more prolonged signaling, right? If you're not breaking it down, it's just hanging out there, so you're able to feel the effects more. So this is particularly useful in Alzheimer's disease, where there's a loss of cholinergic neurons and reduced acetylcholine activity. So donepezil does not reverse the disease, but it can provide modest cognitive improvement and help stabilize symptoms for a period of time. Because acetylcholine also acts in peripheral nervous systems, increasing its levels can lead to side effects such as nausea, diarrhea, and increased gastrointestinal motility. Centrally, it can also cause insomnia and vivid dreams due to enhanced cholinergic activity in the brain. So overall, its effects are modest, but it's widely used because it targets one of the key deficits in Alzheimer's. Okay, then you have scopolamine. And this works in the opposite direction. So it's a muscarinic receptor antagonist, meaning it blocks acetylcholine signaling at muscarinic receptors. And this reduces cholinergic activity, particularly in pathways involved in the vestibular system, which is why it's used to treat motion sickness. So by dampening signals between the inner ear and the brainstem, it reduces nausea and dizziness associated with motion. However, decreasing acetylcholine, especially in the central nervous system, can lead to side effects like confusion, memory impairment, and even delirium, particularly in older adults. So basically, this just highlights how sensitive cognitive function is to acetylcholine levels and reinforces the idea that this neurotransmitter system requires tight balance for normal function. And I like to remember these two because if you have Alzheimer's, you don the pill, you take the pill. It's kind of a stupid way to remember it, but that's one way. So I just remember that guy is very closely linked with Alzheimer's. So you're going to be wanting acetylcholine. And then scopolamine, I remember, to scope a place out, you get in the car, and it's associated with motion sickness, right? Or car sickness is kind of how I remember that one. It doesn't necessarily have to be from a car, but this is just how I remember it. So you're scoping something out in a car, so scopolamine, and you want to reduce, your acetylcholine signaling because you're getting motion sick. So there you go. All right, and now we're getting into dopamine. And remember, dopamine is highly pathway dependent. Okay, so increasing or decreasing it improves some functions, but it will worsen others. Okay, it's a trade-off. So these drugs are essentially pushing the balance in opposite directions like all of our other drugs. Okay, so levodopa is a dopamine precursor, meaning it is converted into dopamine after it crosses the blood-brain barrier. So dopamine itself cannot cross the blood-brain barrier, so levodopa is used as a workaround to increase central dopamine levels. And this is essentially important for Parkinson's disease, where there is degeneration of dopaminergic neurons in the substantia nigra. So by increasing dopamine in the basal ganglia, levodopa improves motor symptoms such as rigidity and bradykinesia, which is slowed movement. However, increasing dopamine is not selective to just motor pathways. Over time, or at higher levels, it can lead to dyskinesia, which is basically just involuntary movements, and psychiatric effects such as hallucinations or psychosis. And this reflects dopamine's role not just in movement, but also in reward and cognition. Haloperidol works in the opposite direction, so it is a D2 receptor antagonist, not an agonist. So meaning it blocks dopamine signaling by reducing dopamine's activity, particularly in the mesolimbic pathway, which we'll get into way later. So it helps decrease psychotic symptoms such as hallucinations and delusions. However, blocking dopamine in the nigrostriatal pathway, which is responsible for movement, can lead to Parkinson's-like symptoms, right? So including rigidity and bradykinesia, which was the exact opposite of what we're trying to fix in levodopa, right? So These are referred to as extrapyramidal symptoms and can also include drug-induced movement disorders, like different types of dyskinesia, okay? The way I like to remember these two is if you want dopamine in your system, right, because you have something like Parkinson's, you want to leave the dopa. Leave the dopa in there, okay? So that's how I remember levodopa. And then haloperidol, I just remember that this one is basically you're hallucinating, right? So you're trying to stop that, okay? So if you're hallucinating, haloperidol, right? Halo, there you go. And you want to stop that, okay? So that one I remember based off of the symptom that it's trying to fix, okay? So when you give haloperidol, it's going to block dopamine receptors, thus basically giving you those Parkinson's-like symptoms, but at the payoff of you're no longer hearing voices, right? Or seeing things. It's pretty nice. Well, you're not hearing voices. That's going to be schizophrenia, which like, this gets tricky. I should keep it light with the jokes, but like that basically, just remember that haloperidol fixes hallucinations. So now we're moving on to the norepinephrine system, and the key idea is that norepinephrine regulates arousal, attention, and signal clarity in the brain, right? That nor, right? The cheeky no. So drugs targeting the system are essentially they're basically tuning how focused and alert neural circuits are, okay? So atomoxetine is a selective norepinephrine reuptake inhibitor, meaning it blocks the transporter that normally removes epinephrine from the synaptic cleft, and this increases norepinephrine levels and prolongs its signaling. In the prefrontal cortex, this is also indirectly going to increase dopamine because dopamine is cleared by the same transporter in that region. So the overall effect is improved attention and executive function, which is why atomoxetine is used in attention deficit hyperactivity disorders, right? Conceptually, it improves the signal-to-noise ratio. Relevant signals stand out more clearly against the background activity. However, if norepinephrine levels become too high, the system starts to overshoot, leading to overstimulation. And this explains the adverse effects of the drug, which include insomnia, increased heart rate, and blood pressure and anxiety. Okay, and then you have venlafaxine, or venlafaxine, and this is a serotonin norepinephrine reuptake inhibitor, or SNRI, and its effects depend on the dose. At lower doses, it primarily increases serotonin, okay? At low doses, it primarily increases serotonin, while at higher doses, it also significantly increases norepinephrine. By boosting both neurotransmitters, it enhances mood and arousal pathways, making it useful in treating depression and anxiety. However, because of its norepinephrine effects at higher doses, it also can increase blood pressure and cause insomnia, reflecting excessive activation of the arousal system. So the key takeaway for norepinephrine systems is that it follows an optimal range, right? Too little leads to fatigue and poor attention, while too much leads to anxiety and impaired focus. These drugs are basically trying to push patients into that optimal middle zone, but side effects occur when they overshoot. I unfortunately don't have a good way to remember these. Like their names are a little crazy. These are the two I just kind of would just put on some flashcards and remember, because there's no fun way to remember them, like levodopa or haloperidol and stuff. Okay, and so this slide covers the serotonin system, also called the 5-HT for 5-hydrotryptamine, and the key idea is that serotonin is a context-dependent modulator, meaning its effects vary based on receptor subtype and brain region rather than producing a signal-predictable outcome. So fluoxetine is a selective serotonin reuptake inhibitor, or SSRI, and it works by blocking the serotonin transporter, which normally clears serotonin from the synaptic cleft. So by inhibiting that reuptake, right, you're no longer clearing out your serotonin from the synaptic cleft, you're leaving it in there. It's going to remain in the synapse longer, increasing that signaling. So this is particularly useful in depression, where serotonergic tone is often reduced, and increasing serotonin can improve mood over time. However, because serotonin acts widely in both the central nervous system and gastrointestinal tract, side effects are common. So these include gastrointestinal symptoms like nausea and diarrhea, as well as sleep disturbances such as insomnia and a sense of restlessness. And so the delayed therapeutic effect, despite immediate increases in serotonin, reflect downstream receptor adaptation rather than simple neurotransmitter levels. Then you have sumatriptan, and this works very differently. So it is a selective serotonin receptor against that target specific 5-HT receptor subtypes, so particularly those involved in cranial blood vessels. So it is used in the treatment of migraines, so where it helps by causing vasoconstriction of dilated cerebral vessels and reducing neurogenic inflammation. This targeted receptor action makes it effective for acute migraine relief rather than long-term mood regulation. However, because of its vasoconstrictive effects, it can produce adverse effects related to blood flow, which is why it must be used cautiously in patients with cardiovascular disease. So, again, the overall takeaway with serotonin drugs is that they can either broadly increase signaling like SSRIs or selectively target specific receptor subtypes like triptans. So because serotonin has a diverse role across brain and body, its pharmacologic effects are very variable. Sumatriptan, I just remember a supermassive headache. So supermassive headache. I know it's a bit of a stretch, but if you've had a migraine, it's not too much of a stretch. So sumatriptan, I just remember, is for migraines. Fluoxetine, honestly, kind of gets a lot of TV exposure. It's used a lot in medical dramas and whatnot because it's a pretty common drug for depression and, SSRIs. Everybody wants to be happy, so it's a pretty common drug. I'd say like a big motivator to know these as future physicians, right? Or whatever field you end up going into in medicine. There's going to be a lot of people in life, right? Family or friends that will try to abuse your medical license to get drugs of different kinds. And it's good to know all the drugs, right? Even if you're never really going to use these in whatever field you think you want to go into, it's good to know these things, right? Because you don't want to be taken advantage of as a physician, right? It's good to know these things. Knowledge is power. All right, and now we're moving on to auditory pathways and language, and so the key idea here is that hearing becomes bilateral very early in the brainstem, which is why central lesions rarely cause complete deafness in one ear. So the pathway begins with the cochlear component of cranial nerve 8, the vestibulocochlear nerve, and these primary sensory neurons carry sound information from the cochlea and terminate in the dorsal and ventral cochlear nuclei in the brainstem, near the inferior cerebral peduncle. At this stage, the information is still ipsilateral, so damage to the cochlear nerve or these nuclei results in ipsilateral hearing loss, okay? So from the cochlear nuclei, second-order neurons project bilaterally, meaning they send signals to both sides of the brain, and this crossing occurs through what's called the trapezoid body. This is a key decussation in the auditory system, okay? So these fibers then synapse in multiple brainstem nuclei, most notably the superior olivary complex. And so the superior olive is important for sound localization as it compares input from both ears to determine the direction of the sound. After this, auditory information ascends in the major tract called the lateral lemniscus, which carries signal up through the brainstem to the inferior colliculus in the midbrain, and the inferior colliculus acts as a major integration center for auditory information, processing aspects like timing and intensity. From the inferior colliculus, fibers travel via the brachium of the inferior colliculus to the medial geniculate nucleus, or MGN of thalamus, and the MGN serves as a relay station for the auditory information before it reaches the cortex. Easy way to remember that too is remember for our visual pathway, we had the LGN, right? The lateral geniculate nucleus, or the lagoon. You see the lagoon. And I just remember that hearing and sound, hearing and vision are very closely tied in your brain, right? So it makes sense to me, at least, right, that vision is going to be the lateral, and then hearing will just be the other guy, which is the medial geniculate nucleus, but they both are from that same kind of area, very closely related. So seeing is your lagoon, and then hearing is going to be your MGN, okay? So finally, from the MGN, third-order neurons project to what's called Heschel's gyrus, which is the primary auditory cortex located in the temporal lobe. And this is where conscious perception of sound occurs. So the big clinical takeaway is that because of early bilateral projection, lesions above the level of the cochlear nuclei typically do not cause complete unilateral deafness, but may instead impair sound localization or processing. And this slide is just going to summarize the auditory pathway lesions. And again, that key concept is where the pathway is still unilateral versus when it becomes a bilateral issue. So at the level of the auditory nerve, meaning the cochlear branch of cranial nerve 8, or at the cochlear nuclei in the brainstem, the pathway is still ipsilateral. And this means that sound information from one ear is still being carried on that same side. And because of that, damage here produces ipsilateral deafness, complete loss of hearing in that ear. This is one of the few places in the auditory system where you can get true unilateral deafness from a single lesion. Once you move beyond the cochlear nuclei, the situation changes dramatically. So second-order neurons project bilaterally again through that trapezoid body, sending auditory information to both sides of the brain. And from this point on, through structures like the lateral lemniscus, inferior colliculus, medial geniculate nucleus of thalamus, and ultimately the auditory cortex or Heschel's gyrus, each side of the brain is receiving input from both ears. And because of this bilateral representation, lesions in these higher structures do not cause complete deafness in one ear. Instead, they just tend to cause more subtle deficits, such as difficulty localizing sound, processing complex auditory information, or distinguishing signals in noisy environments. So complete deafness at these levels would only occur if there were bilateral lesions affecting both sides of this pathway. So again, high yield takeaway. Lesions before the cochlear nuclei cause ipsilateral deafness, while lesions after that point do not unless it's a bilateral lesion. All right, so this slide transitions from hearing into language, and the key idea is that basic sound detection and higher level language processing are not the same thing. So Heschel's gyrus is the primary auditory cortex located in the temporal lobe, and it is where sound is first consciously perceived. It receives input from the medial geniculate nucleus of thalamus. Importantly, damage here does not usually cause complete deafness because auditory input is already bilateral by the time it reaches the cortex. Instead, lesions impair processing. Patients can hear the sounds, but again, may have that difficulty interpreting them or like distinguishing speech or recognizing complex auditory patterns. Speech itself is broken into functional components. So you have articulation, refers to the physical production of speech sounds and is primarily controlled by cranial nerve 12 or hypoglossal nerve. And this is going to innervate that tongue. So damage here leads to slurred or poorly performed words because the motor execution is impaired, right? Like in movies or like apocalyptic movies and stuff, when they like cut off someone's tongue, they just can't talk anymore because there's literally nothing to make the sounds to help articulate the sounds coming out of your mouth, of your larynx. So phonation refers to sound generation, so particularly at the level of the larynx, which is what we just talked about. So this is controlled by cranial nerve 9 and 10 and nucleus ambiguus, which provides motor innervation to the muscles of the pharynx and larynx. And so dysfunction here affects voice qualities, such as hoarseness or inability to produce sound properly. Fluency represents the higher order cortical processing that allows smooth, coherent speech. This involves distributed cortical networks, including regions like Broca's and Wernicke's area. We'll get into those a bit later, but even though they're not explicitly listed on the slide, just know that like disruption at this level affects the ability to generate or comprehend language rather than the mechanical act of speaking it. And like I said, they have their own slide, so don't worry. Clinically, dysarthria refers to difficulty speaking due to motor impairment. The patient knows what they want to say, but the muscle cannot execute the movements properly. So in contrast, dysphagia refers to the difficulty in swallowing, which often involves similar cranial nerves, particularly 9 and 10, and reflect dysfunction in coordinated motor control of the oropharynx. So the overall takeaway is that language depends on multiple systems working together, right? Sensory processing, motor execution, and cortical integration. And lesions in different areas are going to produce very different clinical presentations. All right, so this slide is getting into how reading is not just vision, it's vision plus language integration, and that connection is what makes reading possible. So the process starts with input. So visual information from the eyes travels through the optic pathway and reaches the primary visual cortex in the occipital lobe via the optic radiations. And at this stage, the brain is simply detecting visual patterns, lines, shapes, letters, but there is no meaning yet, right? Next comes processing. The visual information is interpreted in both hemispheres initially, but language is typically localized to the left hemisphere. So for reading to occur, the visual representation of words must be transferred to the left-sided language centers, such as Wernicke's area for comprehension. And this transfer happens through the splenium of the corpus callosum, which connects the occipital lobes and allows information from the right visual cortex to reach the left hemisphere language network. This intra-hemispheric communication is a critical step. If that connection is disrupted, classically by a lesion of the splenium, you get a condition where vision is intact and language is intact, but they can't communicate. So the patient can see words and speak and understand language, but cannot interpret written words, and this is called alexia without agraphia. But So they can't read, but they can still write just fine. The high yield takeaway is that reading requires a bridge between the visual system and the language system, which is the splenium of the corpus callosum, and damage to that bridge produces a very specific disconnection. And we'll also get another clinical correlate once we get into vasculature that ties into this. Okay, so alexia without agraphia. All right, now we have a core map of language in the brain. And the key idea here is that language is not one spot, right? It's a network with specialized roles that communicate with each other. So first we have Broca's area, and it's located in Brodmann areas 44 and 45. And Brodmann areas are just a way to map the brain. These are ones that they love to test on boards and exams, and they just want you to know Broca's and Wernicke's because they're just like the main characters of language. So just know these. I have a fun way to memorize them. I'll let you know at the end. So Brodmann areas 44 and 45 in the dominant hemisphere, and it is responsible for speech production. So it is supplied by the superior division of the middle cerebral artery, which is why strokes here are common in clinical scenarios. So when Broca's area is damaged, patients develop Broca's aphasia. So they understand language relatively well, but they struggle to produce speech. Their speech is non-fluent, effortful, and broken, often described as telegraphic. So I like to think of it as broken speech, right? Broca's. Then you have Wernicke's aphasia in Brodmann area 22, and it's responsible for language comprehension and is supplied by the inferior division of the middle cerebral artery. So damage here causes Wernicke's aphasia, where patients can produce fluent speech, but it lacks meaning. So they cannot understand spoken language, and their own speech may be nonsensical. So the contrast is pretty clean here. So, right, Broca's lesion causes broken speech, whereas a Wernicke lesion causes you to not understand things. And the way I like to remember Wernicke is Wernicke sounds like a messed up way of saying the word, right? So if I'm saying word, but you're hearing Wernicke, something's wrong with your auditory processing, right? So I just remember Wernicke has to do with understanding. Like, what do you say? You're saying Wernicke? And I'm like, no, I'm saying word. Okay, so Wernicke and Broca's. Then you have the angular gyrus, and this plays a higher level integration role. It connects language with other cognitive domains like memory, visual input, and sensory experience. This is especially important for tasks like reading and writing, where you have to link visual symbols to meaning. Then you have the supramarginal gyrus, and it's involved in phonological processing, essentially handling the sound structure of words. So it helps bridge comprehension and production by supporting articulation and phonation planning. So think of it as helping translate what you want to say into a motor pattern needed to say it. I'm using the supramarginal gyrus a lot right now. Finally, the arcuate fasciculus is the white matter tract that connects Broca's and Wernicke's areas. So this connection is critical because language requires that coordination between understanding and speaking. So if this tract is damaged, you basically get what's called conduction aphasia. So patients can understand and produce speech, but they cannot repeat phrases correctly because the connection between comprehension and production is disrupted. So the high yield framework is Broca's produces speech, Wernicke understands it, and the arcuate fasciculus connects the two. The angular and supramarginal gyri act as those integration centers and processing hubs that refine how language is used. Okay, and now I just wanted one slide to basically have a lot of the clinical correlates related to these language centers in one spot here. So we have conduction aphasia, which occurs when the arcuate fasciculus is damaged, right? And that's going to connect your Broca's and Wernicke's areas. So when that's disrupted, the patients can still understand language and produce fluent speech, but they cannot repeat phrases. Okay, so the repetition deficit is the hallmark. If you hear good fluency, good comprehension, but bad repetition, you want to be thinking arcuate fasciculus. And conduction, right? Because a conductor, he waves his arms and then, the orchestra repeats, right? So conduction aphasia is how I remember that. It's not how conduction works, but it's whatever. This is an art school, okay? This is an art school. We're in med school. So conduction aphasia, that's how I remember that. So then you have global aphasia, right? And so this is basically a much larger injury, typically involving the dominant hemisphere territory of the middle cerebral artery. And this hits Broca's area, Wernicke's area, and their connections all at once. And this results in severe impairment of both speech production and comprehension. And patients may only produce a few words or sounds and understand very little. And because of this lesion being so large, it's often also going to be affecting nearby motor pathways, leading to contralateral hemiparesis, and can include something called apraxia. So apraxia is motor planning problem, okay? So not a strength problem. So the patient knows what they want to say, but the brain cannot properly sequence the movements required to produce the speech. And this is different from dysarthria, where the issue is weakness or paralysis of muscles, okay? So a quick way to separate them is apraxia is planning, right? It's a planning issue, whereas dysarthria is basically the muscles are literally paralyzed. Agraphia refers to the inability to write, while alexia, again, refers to that inability to read. And these two often travel together but can be disassociated depending on the lesion. And the big high-yield syndrome with alexia without agraphia, which we touched on in the previous slide, but now we're going to give it the main clinical correlate. We're basically going to fill out that big picture, is the patient, right, cannot read, but they can still write. And this occurs because the visual information cannot reach the left hemisphere, language centers. So, and this is usually due to a lesion involving the left occipital lobe and splenium of the corpus callosum, but most commonly from a posterior cerebral artery stroke. That is the big one, okay? The PCA stroke, okay? So the language system itself is intact, so writing is preserved, but the visual input cannot be interpreted into language, so reading fails. So again, big takeaway is that language deficits are not random. They map pretty cleanly onto this right here. So just look at this for a little bit. These are the big heavy hitters. So we've talked a lot about the left side of the brain, right, with Broca's and Wernicke's, but now we're talking about, real quick, right hemisphere damage leading to something called contralateral hemineglect. So the lesion is typically located to the right parietal temporal cortex, particularly the non-dominant parietal lobe. And this region is critical for attention and spatial awareness and not just raw sensation. So it integrates sensory input and determines what you pay attention to in your environment. So when this area is damaged, patients developed contralateral hemineglect, most commonly left-sided neglect. And importantly, this is not a primary sensory deficit. The eye's visual pathway and somatosensory system may all be intact, but the brain fails to attend to or process stimuli coming from the left side. So in other words, the information arrives, but it is ignored at a cortical level. So clinically, this shows up in really interesting ways. So patients may ignore food on the left side of the plate, or fail to dress on the left side of the body, or deny ownership of their left limbs. And like, for example, when you ask them to draw a clock, they may place all the numbers in the right side. Despite this, if you actively direct their attention to the neglected side, they often perceive and respond to stimuli. So that's the key distinction. It's an attention problem, not a perception problem. So the reason the right hemisphere is emphasized is that it attends to both sides of space, while the left hemisphere primarily attends to the right side. So a right-sided lesion removes attention to the left side entirely, whereas a left-sided lesion is often compensated for by the intact right hemisphere. So that's why left-sided hemineglect forms from right hemisphere damage, and it's much more severe and clinically obvious because you have both of them go into that right hemisphere. So the high yield takeaway is this, right parietal lesions cause left hemineglect, and the deficit is inattention to awareness, not sensation itself. All right, now we're walking through the gustatory pathway, and the key idea is that taste from multiple cranial nerves converge early and then follow a standard sensory relay to the cortex. So taste sensation is carried by 3 cranial nerves, each with its own sensory ganglion. So we have cranial nerve 7, the facial nerve, carries taste from the anterior 2/3 of the tongue and has its cell bodies in that geniculate ganglion. Cranial nerve 9, the glossopharyngeal nerve, carries taste from the posterior 1/3 of the tongue and uses the petrosal ganglion. And cranial nerve 10, the vagus nerve, carries taste from the epiglottis and the lower pharynx with the cell bodies in the nodose ganglion. All of the first-order sensory nuclei converge centrally into the solitary tract and synapse in the nucleus solitarius and the medulla. This is a major integration center, not just for taste, but also for visceral sensory information, which is why it plays a role in autonomic reflexes like swallowing and gagging. And I've touched on this in the previous videos, but repetition's key to memorization, right? So the way I like to remember Nucleus solitarius is that solitarius sounds like a fancy chef, like Chef Solitarius, right? So it's involved in taste, okay, because the chef needs to taste. But it's also a very picky chef. So it pays attention to those baroreceptors and chemoreceptors with your carotid body and sinus, right? With blood pressure monitoring and oxygen perfusion, which is like the weird other thing that salivatory or Nucleus solitarius does. Okay, so I just like to remember Solitarius is our chef. He's our picky chef, right? He likes to taste things. In addition to that, he likes to tweak our carotid body and carotid sinus to make sure nothing wrong is happening. So from there, or he monitors it rather, right? So from there, second order neurons from Nucleus solitarius ascend to the ventral posteromedial nucleus, or the VPM of thalamus. And this is the same thalamic relay that handles sensory information from the face, and it reinforces that taste is grouped with facial sensation at the thalamic level. And remember that we have the VPM and the VPL. VPL is for the lower body, so L for lower body. And then M, I like to remember, is like for mogging or mewing. That's stupid meme stuff from a while ago, but like remember it has to do with, how beautiful your face is. So VP mog, I just remember it's for your face. And so finally, third order neurons project through the posterior limb of the internal capsule to the insular cortex, which serves as the primary gustatory cortex. And this is where conscious perception of taste occurs. So a useful way to frame it is 3 cranial nerves bring in the taste, they merge in the nucleus solitarius, they relay through the VPM, and end in the insula. The high yield pattern mirrors other sensory systems, so peripheral input, brainstem, nucleus, thalamus, then cortex, but with a unique feature of multiple cranial nerves converging early on. All right, and now we're covering olfaction. We've touched on this a lot in the previous videos, but again, repetition, that's what we do. So smell is unique among sensory systems, because it initially bypasses the thalamus, right? It's directly linked to the limbic and cortical regions. So primary olfactory neurons, which are part of cranial nerve 1, are located in the nasal epithelium, and these neurons send their axons through the cribriform plate of the ethmoid bone to synapse in the olfactory bulb, and this is clinically important, again, because of that trauma to that cribriform plate causing anosmia. From the olfactory bulb, second-order neurons project widely to several primary olfactory areas in the brain, and these include the anterior olfactory nucleus, which is involved in modulating olfactory signals and is known to degenerate in conditions like Alzheimer's disease. The amygdala receives olfactory input and links smell to emotional responses, which is why certain smells can trigger strong emotional reactions. The olfactory tubercle in piriform cortex are key areas for processing and identifying odors. The piriform cortex is especially important for smell discrimination and also has connections that project directly to the prefrontal cortex, allowing conscious perception and evaluation of odors. It also sends indirect projections to the medial dorsal nucleus of the thalamus. And another critical structure is the rostro-entorhinal cortex, which connects olfaction to memory systems. So this explains why smells are particularly powerful triggers for recalling memories. After these primary processing areas, olfactory information is relayed to the medial dorsal nucleus of thalamus, which then projects to higher cortical areas for further integration. A defining feature of the olfactory system is that it does not require that thalamic relay before reaching the cortex, unlike other sensory systems. So another unique point is olfactory neurogenesis. Olfactory receptor neurons are one of the few neuron types that can actually regenerate throughout life. So the high yield takeaway is that olfaction is tightly linked to emotion and memory, and they bypass the thalamus early and is vulnerable to damage to the cribriform plate, especially in trauma. And with that olfactory neurogenesis, I know with things like such as COVID, a lot of people lost their sense of smell, and in very rare cases, people never got them back. And the reason, some people either never got them back or they got their sense of smell back, but with just, it was weaker than it was before, is because sure, those neurons regenerated, but the specific tracks connecting them to actual processing no longer have those embryological guidelines to kind of tell them where to go. So you may have functioning neurons, but they're just not sending those signals anywhere because they can no longer retrace their steps to where they need a synapse. So anyway, I just thought that was a cool little tidbit there, because when I was making these slides, I was like, okay, well, what about COVID loss of smell and stuff? So I don't know. It was just kind of cool. So there you go. All right, so this slide is just going to tie olfaction to endocrinology, and the key idea is that smell pathways are physically used during development to guide hormone-producing neurons into the brain. So during embryological development, GnRH neurons, those that will control the reproductive axis, do not start in the brain. They originate in the olfactory placode, which is outside the central nervous system. From there, they migrate along the olfactory pathways into the hypothalamus, and this is a very unusual setup and explains why smell and reproductive functions are linked. So in Kalman syndrome, that migration fails. So the GnRH neurons never properly reach the hypothalamus, so the hypothalamus cannot release adequate gonadotropin-releasing hormone. So without GnRH, the pituitary does not release LH, luteinizing hormone, or FSH, follicle-stimulating hormone, which are required to stimulate the gonads, and as a result, sex hormone production is decreased. So clinically, this leads to hypogonadotropic hypogonadism, meaning low sex hormones due to a problem upstream at the hypothalamus or pituitary level rather than the gonads themselves. And at the same time, because the olfactory system is also disrupted, patients have anosmia or loss of smell. So the classic presentation is a teenager with delayed or absent puberty who also cannot smell. And that combination is a key diagnostic clue. So if you see no puberty and anosmia, you should immediately think of Kalman syndrome. And again, it's because of that failed migration of GnRH neurons along the olfactory pathways. All right, so this slide is going to introduce basal ganglia, and the key idea is that they do not directly generate movement. They control whether movement is allowed to happen. So the basal ganglia regulate access to the motor cortex through a mechanism called thalamocortical disinhibition. At baseline, the system is set up to inhibit movement. So the output nuclei of the basal ganglia, primarily the globus pallidus internus and substantia nigra pars reticulata, tonically inhibit the thalamus. So since the thalamus excites the motor cortex, this means the motor cortex is normally being held back. So movement occurs when the basal ganglia remove that inhibition, essentially cutting the brakes. So the core structure follows a predictable organization. So the striatum, which includes the caudate and the putamen, is the main input center receiving signals from the cortex. The globus pallidus has two parts: the external segment, which is more regulatory, and the internal segment, which serves as a major output of the thalamus. The subthalamic nuclei plays a critical role in reinforcing inhibition within the system. So the substantia nigra has two parts as well: the pars compacta, which serves as dopamine to modulate the system, and the pars reticulata, which functions similarly to the GPI as an output nucleus. The loop is straightforward but essential. So the cortex sends input to the striatum, the basal ganglia process that information, then that output goes to the thalamus, which feeds back to the cortex. And this loop allows the brain to select desired movements while suppressing unwanted ones. So the high yield concept is summarized in this phrase, right? So it inhibits the inhibitor, which allows movement, okay? So because the basal ganglia inhibit the thalamus, you inhibit the basal ganglia output, thus you remove that inhibition on the thalamus, and so the thalamus can then activate the motor cortex and then movement occurs. So I like to think of the basal ganglia as just like the gatekeepers of movement. They are constantly applying the brakes. And the moment, you want movement to happen, right? Movement only will happen when those inhibiting when those inhibiting circuits, right, are lifted at the right time. All right, so this is just going to be a high yield look at each of our basal ganglia, starting with the striatum, okay? So the striatum, again, is composed of the caudate and putamen, and it is the primary input nucleus of the basal ganglia and functions as the main decision point for motor activity. So nearly all motor-related information from the cortex enters the basal ganglia through the striatum, where it is processed before being sent downstream. So the cortex provides excitatory glutamatergic input, essentially signaling intended movements, while the substantia nigra pars compacta modulates this activity through dopamine, fine-tuning how strongly those movements are facilitated or suppressed. Okay, so the neurons that make up the striatum are primarily medium spiny neurons, which are GABAergic. And this is a critical concept because it means the striatum is fundamentally inhibitory. Rather than directly activating movement, it inhibits downstream structures such as the globus pallidus and substantia nigra pars reticulata, and this inhibition ultimately leads to disinhibition of the thalamus, allowing the thalamus to activate the motor cortex. So in other words, the striatum enables movement by inhibiting the structures that normally suppress it. And this is the classic inhibit the inhibitor principle. So the output of the striatum project to key basal ganglia structures, including the globus pallidus internus and externus and the substantia nigra. And these downstream nuclei then regulate thalamic activity, which feeds back to the cortex to execute movement. So the striatum is also part of a broader striatal complex that includes the nucleus accumbens, linking motor control with reward and motivational systems. And so clinically, the striatum is central to understanding Huntington's disease. So in this condition, this is degeneration of medium spiny neurons, particularly those involved in the indirect pathway. And we'll get into the direct and indirect stuff, which is basically going to bring all these ideas together in one place. Okay, so if none of this is really making sense as I'm reading it, don't worry about it. You're going to see the big picture here in a second. So basically, the indirect pathway, what you need to know about it right now is that it serves to suppress unwanted movements. So when this inhibitory pathway is then lost, the system becomes biased towards excessive movement, right? If you don't have the thing that tells you to stop moving, you're going to be moving. And this results in something called hyperkinesia. And this contrasts the disorder with Parkinson's disease, right? Where there's too much inhibition of movement, leading to bradykinesia. Okay, so the globus pallidus is best understood as the final gatekeeper of movement output in the basal ganglia. It has two parts that do very different jobs. So the globus pallidus internus and the globus pallidus externus. So if you keep those two roles straight, most basal ganglia questions become pretty manageable. So the GPI, or globus pallidus internus, is the main output nucleus of the basal ganglia, and it projects to the ventral lateral nucleus of the thalamus. So functionally, GPI is tonically active and inhibitory, or GABAergic. So that means it's constantly suppressing the thalamus under normal conditions. And because the thalamus is what excites the motor cortex, this constant inhibition acts like a brake on movement. And this is where the high yield rule comes in. When the GPI is active or on, it strongly inhibits the thalamus, so the thalamus cannot stimulate the cortex, so thus movement is off. When GPI is inhibited or off, the brake is removed, so the thalamus becomes active and it excites the motor cortex, so movement is turned back on. So GPI is not generating the movement, it's just controlling whether movement is allowed to pass through. The GPE, globus pallidus externus, in contrast, is not a direct output of the thalamus. Instead, it plays a regulatory role with the basal ganglia loop, especially through its interactions with the subthalamic nucleus, or STN. The GPE normally inhibits the STN. When that inhibition is reduced, the subthalamic nuclei become more active and excite the GPI, the globus pallidus internus, which increases thalamic inhibition and suppresses movement. So this is the key part of the indirect pathway, which has its own slide, and it's the system's braking circuit, right? So one important thing to note is that the globus pallidus can be lost in Alzheimer's. It's not like the main thing, but it just can be. But it's good to know that Alzheimer's primarily affects cortical regions like the hippocampus and association areas. So when you think of degeneration, though, tied to basal ganglia, again, that high yield one to keep in mind is Huntington's disease, which is striatum loss, leading to hyperkinesia, and Parkinson's disease because of dopamine loss, leading to excessive globus pallidus internus activity, leading to hypokinesia. And we'll get into that later, again, just this repetition. All right, so the subthalamic nucleus, or STN, is a small structure with a disproportionately large impact on movement because it acts as a key excitatory driver of the globus pallidus internus. So unlike most of the basal ganglia, which are predominantly inhibitory, the STN uses glutamate and therefore excites its target, most importantly the GPI. So it's a little bit weird in that it excites its target that happens to be an inhibitor. So functionally, the STN is a central component of the indirect pathway, or decreasing movement, right? So when the indirect pathway is activated, the STN becomes more active and sends excitatory signals to the globus pallidus internus, or GPI, and this increases the GPI activity, which in turn increases inhibition of the thalamus. And since the thalamus is responsible for exciting the motor cortex, this chain of events results in reduced thalamic output and suppression of movement. So in simple terms, the STN helps shut movement down by exciting the GPI's inhibitory effects. So you can think of the STN as basically just an amplifier of inhibition, right? Clinically, this becomes pretty important for lesions because damage to the STN removes this excitatory input to the GPI. And as a result, the GPI becomes less active. So you're not going to be inhibiting that thalamus as much as you want. So you're going to have a lot of unwanted movement. And this leads to something called hemiballismus, which is characterized by violent flinging movements of the limbs on the sides opposite of the lesion. So it is essentially the system losing its major brakes. Okay? So again, just remember, STN excites that GPI to suppress movement. Okay? If those brakes fail, it results in those excessive uncontrolled movements. All right, so the substantia nigra, we've talked about it a lot. Now it's getting its own little slide here. So again, it's the modulatory engine of the basal ganglia, and the easiest way to understand it is to separate it into its two functionally distinct parts. You have the substantia nigra pars compacta, or the SNPC, and then you have the substantia nigra pars reticulata, or the SNPR. So the SNPC is dopaminergic and projects to the striatum, so where it fine-tunes movement by acting on two different receptor populations. So dopamine has a dual effect that ultimately promotes movement through two complementary mechanisms. On D1 receptors, which are part of the direct pathway, so wanting to increase movement, dopamine is excitatory and strengthens this pathway. So since the direct pathway facilitates movement by inhibiting globus pallidus internus, this leads to increased thalamic activity and more movement. On D2 receptors, which are part of the indirect pathway, so decreasing movement, dopamine is inhibitory. So this suppresses the indirect pathway, which normally acts as a brake on movement. So by weakening this brake, dopamine again is promoting movement just through an inhibitory way, right? Both D1 and D2 receptors are both trying to increase movement. One is doing it directly by exciting the thing that does movement, and the other one is causing movement by inhibiting the thing that decreases movement. So this is why loss of SNPC neurons, as seen in Parkinson's disease, causes hypokinesia. Without dopamine, the direct pathway is underactive and the indirect pathway is overactive, leading to excessive globus pallidus internus activity and too much inhibition of the thalamus. So the cortex is then understimulated, producing the classic symptoms of bradykinesia and rigidity. The substantia nigra pars reticulata, or the SNPR, is, in contrast, not a modulatory, but functions as an output nucleus, similar to globus pallidus internus. It's GABAergic and sends inhibitory signals to targets such as the thalamus and the superior colliculus. Its role in the superior colliculus is especially important for controlling eye movements, particularly saccades. So you can think of SNPR as extending basal ganglia control beyond limb movements into a visual motor coordination. But honestly, the SNPC is the big high yield one here, right? So it provides dopamine to increase movement via D1 activation and D2 inhibition, while the SNPR acts like the GPI as an inhibitory output nucleus, especially for eye movement control. And now we just have a big map putting all this together, and this is where all this basal ganglia shenanigans should click into place, okay? So we have two major movements here, two major pathways. We have more movement, which is the direct pathway, and we have less movement, the indirect pathway. So in the direct pathway, the cortex activates the striatum. The striatum then inhibits the globus pallidus internus, and since the globus pallidus internus is the thing that's inhibiting the thalamus, shutting down the GPI is like removing that brake, right? So then the thalamus is finally free to activate the cortex and movement occurs. So the logic is cortex to striatum. The striatum then inhibits GPI, the thalamus is then freed, and then the cortex fires, and then you have movement. And this is why it's called disinhibition. You are not directly activating movement, you are removing the thing that was stopping it. So just remember, direct pathway cuts those brakes, right? Indirect pathway, less movement. So it adds an extra loop that ultimately does the opposite. So the cortex still activates the striatum, but now the striatum inhibits the globus pallidus externus instead of the globus pallidus internus. So instead of inhibiting that GPI, we're now inhibiting the GPE, okay? So the GPE normally inhibits the subthalamic nucleus. So when GPE is inhibited, the subthalamic nucleus becomes more active. So the subthalamic nucleus then excites the globus pallidus internus, making the GPI more active, and that means stronger inhibition of thalamus and less cortical activation and less movement. So the logic is the cortex goes to the striatum, then from the striatum is going to inhibit GPE, okay? And then globus pallidus externus, since it's shut off, no one's there to inhibit subthalamic nuclei, so then they're like, oh yay, we're free to excite globus pallidus internus. So STN goes and excites GPI, and GPI is like, great, I'm good to go. No one's inhibiting me. Time to suppress the thalamus. So it inhibits the thalamus, and then you have less movement. So just remember, indirect pathway is like slamming those brakes. You're upregulating GPI, whereas the direct pathway, you're destroying GPI. I mean, you're not destroying, you're inhibiting it, but just to put it nice. And here's just a lovely diagram that my professor used. If you're more of a diagram person, pause it here, take a look at this, draw this out on your piece of paper a couple times. I like to kind of give all of these little nuclei their own little personalities, because honestly, the basal ganglia, I like to think of them as a bunch of like teenagers that are all gossiping to each other and who said what, causing what else to happen. So if you find a way to, a nice way to map it out in your brain, here's a nice little framework for that. So this slide is where the basal ganglia stop being abstract and turn into like more testable clinical patterns, aside from like those indirect direct pathways, like do you just know the steps? So we're going to start with the big divide. So hypokinetic versus hyperkinetic disorders. And that distinction is entirely about how much the thalamus is being inhibited, right? So in hypokinetic disorders like Parkinson's disease, there's too much globus pallidus internus activity, which means excessive inhibition of the thalamus. The cortex doesn't get enough stimulation, so movement is reduced. The root problem in Parkinson's is that loss of dopamine from substantia nigra pars compacta. So without dopamine, the direct pathway is weakened and the indirect pathway becomes relatively overactive. So the net effect is that GPI is firing more than it should, clamping down on the thalamus and producing bradykinesia and rigidity. In hyperkinetic disorders, the opposite is happening. So the GPI is underactive, so the thalamus is not properly inhibited. That leads to excessive cortical activation and too much movement. So in Huntington's disease, the indirect pathway degenerates, removing the system's ability to apply the brakes. So with less activation of GPI, the thalamus becomes disinhibited, producing unwanted movements, right? So in hemiballismus, the issue is more focal. A lesion of the subthalamic nucleus, right? So since the subthalamic nucleus is normally what excites GPI, making it inhibit the thalamus, when you lose that subthalamic nucleus, right? There's no one saying, hey, let's inhibit the thalamus, guys, right? So again, the thalamus escapes that inhibition, but this time the result is even more violent, and and you get flinging movements rather than just unwanted little movements, okay? So then we have deep brain stimulation, and this is just a clinical correlate that my professor brought up, and honestly, I don't even know if it's going to be clinically, or it's obviously clinically relevant, but on the exam, I don't know. But I'm just putting it here for completion's sake. And it's essentially just a way to manipulate the circuitry therapeutically. So in Parkinson's disease, electrodes are typically placed in structures like the subthalamic nucleus or GPI. Although the exact mechanism is complex, the functional effect is to reduce the overactivity of GPI. So either by modulating subthalamic nucleus output or directly altering globus pallidus internus signaling, this decreases inhibition of the thalamus, allowing more cortical activation and improving movement. So too much GPI activity means too little movement. That's pretty much Parkinson's. Too little GPI activity, you get too much movement. And that's when you see things like Huntington's and hemiballismus. But remember, with hemiballismus, you have that subthalamic nucleus correlation. Okay, so this slide is basically your thalamus is the control tower concept, right? And if you frame it that way, things kind of start to become intuitive. So the thalamus sits between incoming information and the cortex. So that's why it's often called the gatekeeper, right? And processor. So with one major exception, you have olfaction, right? Olfaction skips the thalamus, okay? So all sensory information must pass through the thalamus before reaching the cortex, except for olfaction. It doesn't just relay signals passively. It actively filters them, prioritizes them, and modulates what gets through. So think of it like a wire, and think of it less of a wire and more like a traffic air controller, right? Who's deciding what's getting through, right? Or what's circling, okay? So the thalamic nuclei are organized by function. The relay nuclei are the most straightforward. They take specific sensory or motor information and send it to defined cortical areas. So for example, the VPL and the VPM, right? They handle somatosensory input, while the VL nucleus relays motor information from the basal ganglia and cerebellum to the motor cortex. These are high yield because they are point-to-point transmitters. The association nuclei are more integrative. So instead of relaying raw sensory data, they connect different cortical regions to each other, helping coordinate higher order processing like cognition and planning. And these are less about where does the signal go and more about how do cortical areas communicate. The intralaminar nuclei are tied to arousal and alertness, and they are part of a broader system that maintains consciousness, which is why thalamic damage can have a profound effect on wakefulness. Okay, the reticular nucleus, or the TRN, is the most conceptually interesting. It doesn't send signals to the cortex. Instead, it inhibits other thalamic nuclei, and it acts as a regulatory shell around the thalamus, controlling the flow of information. So this makes it central to attention and consciousness because it can selectively dampen or allow signals to get through. If the thalamus is a control tower, the TRN is the person dimming or spotlighting specific runways. Right? And I like to remember that because I like to think of it as like the switch for the thalamus of like what it's supposed to be focusing on. So TRN is the short way of saying reticular nucleus. So I like to say it turns the attention of the thalamus, TRN, right? Turns the attention of the thalamus. So there you go. Okay, again, and we're just doing a little bit of a closer look of what goes where in the thalamus. And this is very testable. So the sensory relay nuclei, again, are you have your VPL and VPM. And VPL is going to handle all that sensation from the body, the lower, right? L for lower, so VPL, lower, okay? VPM is going to be the face equivalent, okay? So it's receiving input from trigeminal pathways. If you see a question about face versus body sensory loss, you're deciding between VPM or VPL. Then you have the LGN, the lagoon, and the MGM, or MGN. And these are easier, again, because they just handle one thing. So the lagoon is for vision, right? You see the lagoon, the LGN, okay, the lateral geniculate nucleus. And then you have the MGN, which is for hearing. And remember, I like to remember that because hearing and vision are tied very closely together with your reflexes, with your superior and inferior colliculus. They're always like next to each other, So, I mean, this one, if you know the lagoon thing, you can just remember that the MGN is for hearing, okay? Then on the motor side of things, you have the VA and the VL nucleus, and they're doing something different. So they are not initiating movement. They are modulating and refining it. They receive input from the basal ganglia and cerebellum, which are both those fine-tuning systems, and then they send that information to the motor cortex. So the cortex still decides to move, but these nuclei, the VA and VL, influence how well that movement is going to be executed. And then finally, the key conceptual distinction is this, right? So sensory nuclei relay information to the cortex. Motor nuclei adjust cortical output based on subcortical feedback from basal ganglia and cerebellum. If something goes wrong in the VA and VL, you don't lose the ability to move, you just get poorly coordinated or improperly scaled movements, okay? Okay, and so these slides are a little less obvious, but just as testable. So you have the pulvinar and lateral posterior nuclei, and these are heavily tied to visual attention and integration, not just raw vision. They receive input from that superior colliculus, which is tied to vision, right? Or specifically like your visual reflexes, right? Which is involved in that orienting movements like turning your eyes, head towards stimuli. So these nuclei help coordinate where you pay attention visually. If something disrupts them, it's less about blindness and more about impaired visual attention or neglect like phenomena. The way I like to remember that is pulvinar sounds like pulverizing, and if you see someone getting pulverized, you're going to look over there. You're going to be like, oh my God, what? Right? So pulvinar. Lateral posterior, you just got to remember that comes with it. But start with that pulvinar association and then try to slowly add in that lateral posterior association there. Then we have the dorsal medial nucleus, and this is more of a limbic association hybrid. It connects strongly with the prefrontal cortex and is involved in emotion, behavior, decision-making, and some sensory integration, including olfaction. So clinically, this is one of those nuclei where lesions don't give you a clean deficit, like I can't feel my arm, and instead you get personality changes, impaired judgment, or altered emotional processing. Then you have the intralaminar nuclei, which are CM and PF, and these are part of the arousal system. So they project diffusely to the cortex and basal ganglia and are important for wakefulness and attention. So think of them as part of the background on switch for the brain. Damage here can contribute to decreased consciousness or attention deficits, but not focal sensory loss, okay? Then you have the reticular thalamic nucleus, again, that TRN, which is that control gate for the entire thalamus. It is inhibitory, so GABAergic, and wraps around the thalamus, regulating what signals get through. Remember, it turns the attention of the thalamus, TRN. It plays a major role in sleep-wake cycles. Another way I remember that is you turn in your bed as well, right? So there's that. And attention filtering, right? So when it's active, it suppresses thalamic relay activity, and when it relaxes, more information reaches the cortex, and this is why it's central to sleep rhythms like sleep spindles, which we'll get into way later, and selective attention. So if you zoom out, the pattern is pretty consistent here, right? So these nuclei are not about what information is being sent, but about how strongly, where, and whether that information gets processed at all. They're basically like micromanagers, they're like the Karens of your brain. That's, basal nuclei and thalamic nuclei. They're always like, they're like actually kids. Like, actually, you need to do it like this. That's how I like to think of these guys. All right, so now we have that deep dive into the thalamus tying into the limbic system. Which is where things shift from relay station to more behavior and memory and emotion integration. So the anterior nucleus is the cleanest one conceptually. It's part of something called the Papez circuit, which we'll get into. But in short, you should think of it as a loop for memory and emotion processing. Information comes from the mammillary bodies via the mammillothalamic tract and gets sent to the cingulate gyrus and eventually loops back to the hippocampus. If this pathway is disrupted, you get memory deficits, especially seen in conditions like Korsakoff syndrome. And this is one of those, just know the circuit for structure of exams. And I have a whole slide for the Papez circuit later on, so don't worry about it. The lateral dorsal nucleus is more of an association extension of that same system. So it also connects the hippocampus to cortical areas like the cingulate, prefrontal, and parietal cortex, but functionally it helps integrate memory with higher order processing, meaning it contributes to how memories influence attention, planning, and perception rather than just storing them. The dorsal medial nucleus shows up here again because it's reinforcing that it sits at the intersection of cognition, emotion, and motivation. It has a strong connection with the prefrontal cortex, so it's involved in executive function, decision-making, and emotional regulation. The schizophrenia note here is really high yield, so reduced dorsal medial nucleus activity correlates with disorganized thinking and impaired cognition, which fits its role as the bridge between limbic input and frontal lobe output. Okay, so the unifying idea is that these nuclei are not just passing signals, they are embedding emotional and memory context into cortical processing. So if the sensory thalamus tells you what you are perceiving, the limbic thalamus helps determine what it means to you, right? And how you respond to it, right? If your significant other is stroking your face, you're not reading that as a threat. You're like, we're about to have a great time. These guys are important for that. All right, so this is where the thalamus stops being just a relay and goes very clinical, okay? So the firing modes are about how much information the thalamus allows through. In the tonic or awake state, neurons are relatively depolarized and fire in a steady, linear way, which means accurate transmission of sensory information in the cortex. In contrast, the burst mode happens when neurons are hyperpolarized, typically during sleep or strong inhibition. And the thalamus essentially gates input. So information flow is reduced or distorted, and this is how your brain prevents sensory overload during sleep. The reticular thalamic nucleus, right, the TRN, is the key regulator here. It's inhibitory and acts like the dimmer switch, right? It's controlling whether the signals pass through cleanly or get suppressed. And it's like, hey, you're sleeping right now, right? You're turning in your sleep, so I'm going to make sure that you're not going to get woken up by the baby that you share a wall with that screams every night at like 11 p.m. or 12 p.m. And you're not going to get angry about it because the parents definitely like have it way worse off than you, and you're just going to lie there in your bed and you're going to be like, this is fine. Clinically, lesions depend heavily on which nuclei are hit. A small stroke affecting the VPL or the VPN gives a very clean finding. Okay, so contralateral loss, body for the VPL and face for the VPM, remember that MOG association? That's a classic localization question. So when lesions are larger or bilateral, they start affecting the intralaminar or arousal systems, leading to a decreased consciousness because you are disrupting the thalamus role in keeping the cortex awake. The high-yield pathology here is thalamic pain syndrome or DeJean-Rousey syndrome, and this is usually from a PCA infarct hitting the VPL and VPM. So initially, patients have contralateral sensory loss, but over time, that will evolve into a severe burning, poorly localized pain with hyperalgesia. It's paradoxical because you damage a sensory relay, so you would think, like, I'm not feeling anything, but instead of just losing sensation, it actually starts malfunctioning and starts becoming overactive instead. So you start feeling pain when you literally have nothing happening, or it's like a very slight stimulus, like a feather brushing on you. So the pattern to remember is straightforward here, right? Precise lesions give clean sensory deficits. Larger or evolving lesions cause global effects like altered consciousness or disordered pain perception. All right, so think of the internal capsule as a high-density fiber bottleneck, huge amounts of information packed into a very small space. And that's why even a tiny lesion here causes big, clean deficits. So the anterior limb mainly connects the thalamus to the prefrontal cortex. So it's about cognition, planning, and behavior. Lesions here are less dramatic motor-wise, but can affect executive function and motivation. The posterior limb is one that you absolutely must know. So it carries corticospinal or motor and major sensory pathways. So damage gives you contralateral weakness and sensory loss. And this is a classic lacunar stroke presentation, pure motor stroke, pure sensory stroke, or both. If a question gives you face, arm, leg, weakness, all on one side with no cortical signs, you should immediately be thinking internal capsule, and specifically posterior limb. The the retrolenticular part carries optic radiations. So lesions here cause visual field deficits, classically homonymous hemianopia. So the sublenticular part carries auditory radiations, which are less commonly tested but tie into hearing pathways to that MGN. And just remember, like, this connection between auditory and visual pathways, they're always together, right? So you have the retrolenticular part, which is carrying those optic radiations, and then you have the sublenticular part, and that's carrying those auditory radiations. And so the big picture rule is this, right? So the internal capsule is not doing processing, it's just transport. So lesions don't give weird complex syndromes. Instead, they give dense, pretty straightforward deficits because you're cutting major highways of information all at once. All right, we're about halfway through the video and a little behind the scenes, MooseMed, but I went and got myself a Diet Dr. Pepper. I don't know if you guys knew this, but this channel runs on the stuff. So here's to halfway almost done with neuro. Oh yeah. Delicious. Okay, with that said, let's do the rest of the diencephalon, which is basically everything but the thalamus, okay? Because remember, the diencephalon is our thalamus city, USA, okay? So the epithalamus is dominated by the pineal gland, which regulates circadian rhythm through melatonin. Light input indirectly controls it, so it's your brain's internal clock. And the habenula is a less obvious but a high-yield part. It links the limbic structures to the midbrain systems, so especially dopamine pathways, and is involved in reward, aversion, and mood regulation. So think of it as a negative feedback/reward processing hub. I like to remember that the epithalamus has to do with melatonin and sleeping because, like, it's the epithalamus, so there's that. The subthalamus is functionally part of the basal ganglia. So even though anatomically it sits in the diencephalon, its key structure is, we've already learned it, it's the subthalamic nucleus, the STN, which, remember, excites its globus pallidus internus and therefore suppresses movement via the indirect pathway. So when you knock it out, you lose that break, and the rest is and the result is hemibolismus, right? Those large flinging contralateral movements to the lesion, and this is one of the cleanest lesions, right? The symptoms are those relationships in neuro. So the hypothalamus is the control center for homeostasis, right? We covered this in EndoRepro. It integrates autonomic and endocrine function and communicates directly with the pituitary, and this is where you regulate temperature, hunger, thirst, stress response, and circadian rhythms. So unlike the thalamus, which it relays, the hypothalamus acts, it changes physiology in real time. So remember, thalamus is a relay, hypothalamus is that regulator with endocrinology. Subthalamus is motor modulation via the basal ganglia with those subthalamic nuclei, and epithalamus is the epithalamus, and it's circadian rhythm and the limbic linkage. Okay, so the limbic system is essentially the interface between feeling, memory, and action. It takes emotional significance and attaches it to experience, and then influences behavior and physiology through heavy connections with the hypothalamus. So that's why emotions can change heart rate, appetite, stress responses, etc. It's not abstract, right? It's wired directly into your body. So the limbic lobe, which is the cingulate gyrus and the parahippocampal gyrus, as well as the uncus, is the cortical surface component. The cingulate gyrus is particularly important for emotion processing and attention, while the parahippocampal region is tied to memory encoding and spatial contextual awareness. The uncus is clinically relevant because it sits near the medial temporal lobe, and you want to be thinking uncal herniation affecting nearby structures, and we'll get into that clinical correlation in a second. The subcortical components are where the major functions live. So the hippocampus is responsible for forming new memories, right? You will never forget a hippo on campus. That's how I remembered it for the MCAT. It's a good way to just remember that. The amygdala assigns emotional valence, especially fear and threat. And the mammillary bodies and the anterior thalamus are part of that PAPES circuit that I said that we will get to, and I promise it's coming. Not yet, but it's coming. But it just reinforces memory processing. The fornix is the major white matter tract connecting the hippocampus to the mammillary bodies. So if you disrupt that, you disrupt memory flow. So if you zoom out, the system works like this. The amygdala says, this matters emotionally. The hippocampus says, remember this, store it. The hypothalamus says, adjust the body accordingly. And that's why limbic lesions don't give simple deficits like weakness or numbness. They give personality changes, memory loss, emotional dysregulation, or abnormal motivation. The limbic lobe is where emotional meaning gets integrated with higher cognition, and this slide is really about functional specialization within that system. So the cingulate gyrus is the key bridge between thinking and feeling. So the anterior portion is tied to motivation, behavior, and attention. So lesions here often look like apathy or reduced initiative rather than a classic neurological deficit. The posterior horn is more about memory and learning, so linking closely with hippocampal circuits. A useful way to think about it is anterior is your drive, while posterior is the memory context. Then you have the parahippocampal gyrus, and this acts like a gateway into the hippocampus. it takes processed cortical information and follows it into the hippocampus for memory formation. So if this region is disrupted, the issue isn't emotion, it's the inability to properly encode new experiences into memory. So I just remember that, right, the hippocampus is involving memory. You never forget a hippocampus. And if something is next to it, aka the parahippocampal gyrus, it's going to facilitate that process. So just know it helps with that. The uncus is a small region, but clinically important. It's part of the primary olfactory cortex and also interfaces with the amygdala, which is why it's tied to fear and emotional processing. This is also the region involved in uncal herniation, so where the medial temporal structures compress the brainstem, and it's going to show up in both neuroanatomy and clinical emergency scenarios, and it has a whole slide for that later on. So the pattern here goes: information flows from the cortex, parahippocampal region, then it goes to the hippocampus, while the cingulate gyrus integrates how much it matters and how much you should act on said thing that you're encoding. All right, and now we have that subcortical component of the limbic system, and again, this is going to be the core circuit of memory and emotion. And you should read it as one continuous loop rather than separate structures, right? Okay, this is a circuit, okay? And again, I know I'm like dancing around the PAPES circuit. It's coming, I promise. So we're just learning the components of everything first. So the hippocampus sits in the medial temporal lobe and is responsible for converting short-term memory into long-term memory. When it's damaged, patients can't form new memories, and this is called classic anterograde amnesia. Old memories are often preserved because they've already been distributed to the cortex, but you can't make new ones. The amygdala runs in parallel but adds emotional weight. It determines what is important or threatening, especially fear-related processing. This is why emotionally intense events are remembered better. The amygdala is essentially tagging them as, you need to store this. From the hippocampus, information travels through the fornix, which is the main output tract, and the fornix carries signals to the mammillary bodies in the hypothalamus. The mammillary bodies then relay that information via the mammillothalamic tract to the anterior nucleus of the thalamus. The anterior thalamus then sends that processed information up to the cortex, and especially the cingulate gyrus, completing this loop. And guess what, guys? This entire pathway is the PAPES circuit, and it's fundamental for memory consolidation. So compressing it into one flow, okay? It goes from hippocampus to the fornix, to the mammillary bodies, to the anterior thalamus, to the cortex, then back to the hippocampus, and then repeat. Remember, it's a cycle. It's a circuit. So clinically, this matters because damage anywhere along this circuit, whether it's the hippocampus, the mammillary bodies, etc., can produce memory deficits, even if the rest of the brain is intact, okay? All right, so here we're going to be tying together the two loops you need to keep distinct but connected. So the first one is the big memory emotion loop. That's PAPES circuit. And then there's the second loop, which is the micromemory circuit inside the hippocampus, and that's called the perforant pathway. So let's start with the hippocampal formation. This isn't just the hippocampus, it's a functional unit made of the dentate gyrus, the hippocampus proper, the subiculum, and the entorhinal cortex. Think of it as the brain's memory processing pipeline. This is where information gets encoded, processed, and prepared for a long-term storage. Now, zooming out, we have the PAPES circuit, which is the full loop that connects memory to emotion. Information flows from the cingulate gyrus, which is the cortical input, down to the hippocampus, then exits via the fornix to the mammillary bodies. From there, it travels through the mammillothalamic tract to the anterior nucleus of thalamus, which sends it back to the cingulate gyrus, completing the loop. And this loop is what integrates memory with emotional context. It's why memories aren't just facts, they have emotions that are tied to them. Now, the perforant pathway is different. It's the internal circuitry of the hippocampus itself, and this is where the actual encoding happens. Input comes from the entorhinal cortex, which is basically the gateway for the cortex into the hippocampus, and then it goes from the entorhinal cortex to the dentate gyrus, and then it goes to CA3, then to CA1, to the subiculum, and then to the fornix. And this sequence is high yield. If you see CA1 or CA3 on an exam, there's steps in this pathway. Conceptually, here's a clean way to think about it, right? So the perforant pathway is, again, processing the memory. The PAPES circuit is distributing and integrating that memory with emotion. So clinically, damage to the hippocampal formation, especially CA1, which is very hypoxia sensitive, right? It will disrupt memory encoding, while damage along the Pepez circuit, like the mammillary bodies and alcoholism, disrupts memory consolidation and recall, which is why, if you have some heavy drinking, you don't necessarily remember the night before. Okay, so this slide is very testable because it links structure with behavior change. So start with the amygdala. Its core job is threat detection, right? And assigning emotional significance, especially fear. So if you lesion that thing that encodes fear, the patient doesn't just feel less scared, they literally cannot recognize danger appropriately. So they may approach harmful stimuli because the brain never flags it as threatening. So now extend that to Kluver-Bucy syndrome. I'm doing my best here. And this is what happens when you get bitemporal lobe damage, including the amygdala. So it's a full behavioral syndrome. So the classic features all come from losing emotional filtering and inhibitory control. You get hypersexuality because behavioral restraint is gone, docility because aggression and fear circuits are impaired, and lack of fear because the amygdala isn't functioning. So the visual agnosia piece comes from temporal lobe involvement. Patients can see objects but can't recognize what they are. The everything goes in the mouth line is basically just describing hyperorality, which is another key feature. So without proper evaluation of stimuli, the brain defaults to primitive exploratory behavior, which is, let me just put it in my mouth. A clean way, right, just to frame this is amygdala, right, is going to assign that emotional meaning of fear. So if you remove it bilaterally, the brain becomes behaviorally disinhibited, fearless, and inappropriate. Okay? The reason we have the climber on here is I brought this up on another MooseMed, but just in case not everybody watched them because I know they're long and people skip around, totally fine. But this is just great documentary, free solo. They took this famous rock climber, Alex Honnold, to get an MRI. Sorry, it's been a minute since I've seen it. And his amygdala was tiny. It was shrunken, which is pretty funny. And you can also kind of see it in the way he behaves around his girlfriend. Like, there's literally an interview where they're like, aren't you afraid you're going to die? Like, aren't you afraid you're going to... He's like, it's a hobby. It's whatever, there's danger everywhere in the world. And then they interview his girlfriend. And he's like, are you worried he's going to die? She's like, honestly, yeah. And we tried talking to him about it. And, he just kind of doesn't care. So he may have some of the hallmark features of Kluver-Bucy syndrome, but maybe not the compulsive eating part. But... because it's not bitemporal, but it's just an interesting correlate there. And also, while I'm rambling, I'm also realizing that these images on the bottom are probably AI generated, which is really sad. Because I get my images either from Google Images, and so I just kind of pick what shows up first. I'm seeing these ladies' fingers, and they're starting to multiply. That sucks. Oh my gosh, dead internet theory, guys. Oh man. Okay, anyway, we're med school. Moving on. All right, so again, we just have some more vasculature. So the cingulate gyrus sits on the medial surface of the brain, so it's supplied by that anterior cerebral artery, ACA. So if it's compromised, you're not just thinking about leg weakness, you also get changes in motivation, attention, and behavior because the cingulate gyrus, again, is part of that frontolimbic interface. Then you have the perihippocampal gyrus, and it is on the inferior medial temporal lobe, which puts it in a posterior cerebral artery territory, so PCA, and that's why PCA strokes often have memory and visual association deficits. They're hitting structures involved in memory encoding and contextual processing. The uncus is more lateral and anterior temporal, so it falls under the middle cerebral artery supply. And clinically, this matters because the uncus is involved in olfaction and emotional processing, and it's also the structure that herniates in an uncal herniation compressing cranial nerve 3, which is the little correlate there. So the high-yield piece here is deep limbic structures, like the hippocampus and the amygdala, are supplied by anterior choroidal arteries, and this is a branch of that internal carotid, and it shows up on exams a lot. So if this artery is hit, you can see memory deficits, like problems with the hippocampus, right, and emotional and behavioral changes, which would be problems with that amygdala. But if it's a stroke of that, of the anterior choroidal artery, you'll see those presenting together. All right, so just some more vasculature here for deep brain structures. So starting off with the recurrent artery of Hübner, which comes off of the anterior cerebral artery, or ACA, and it supplies the anterior basal ganglia and anterior limb of the internal capsule, including the head of the caudate, parts of the globus pallidus, and nucleus accumbens. Functionally, this region is tied to motivation, behavior, and frontal limbic circuits, so lesions here don't usually give you a dramatic paralysis. They give you more subtle findings like a lack of initiative. So behavioral changes, you want to be thinking cognitive slowing, sometimes with mild motor deficits if that internal capsule is more involved. Now, contrasting that with the lenticulostriate arteries, which come from the MCA, these are stroke factory vessels, small, deep, and highly vulnerable, okay? These supply most of the basal ganglia and internal capsule, especially the genu and posterior limb, which carry corticospinal and corticobulbar fibers, and this is where things get clinically pretty obvious. So if you knock out the posterior limb of the internal capsule, you hit dense motor fibers, so you're going to get contralateral pure motor hemiparesis. So no cortical signs, no sensory loss necessarily, just clean, severe weakness. That's a hallmark for a lacunar stroke pattern. The medial versus lateral distinction on the slide here is just telling you how broadly these vessels cover the basal ganglia, but the key takeaway is a little bit simpler, right? So Hübner, ACA, is going to be anterior behavioral and mild motor deficits, where the lenticulostriate, the MCA, is going to be a deep motor highway, so you're going to see some major weakness there. So if you see a question describing a patient with sudden, isolated contralateral weakness without aphasia or neglect, think lenticulostriate infarct of the internal capsule. That's one of the most high-yield stroke patterns there. All right, so now we're moving on to that PCA, and so we're going to start with the posterior choroidal arteries. And these supply a mix of posterior thalamus and limbic-related structures. The medial branches hit the medial posterior thalamus, pineal gland, midbrain, and choroid plexus of the third ventricle, while the lateral branches cover the posterior and lateral thalamus, including the pulvinar nucleus. You got the hippocampus, you got the fornix, and lateral ventricular choroid plexus. The key takeaway is that these vessels tie together thalamus and memory circuitry, right? So hippocampus and fornix. So lesions here can give you memory issues, plus higher order sensory integration problems. So not just simple deficits. Next are the thalamo-perforator arteries, and these go straight into the medial thalamus and upper brainstem. This region is tied to arousal, consciousness, and eye movement control. So if these are hit, you want to be thinking decreased consciousness, confusion, or coma, sometimes the ocular motor abnormalities. Then you got the thalamo-geniculate arteries, which are very high yield, and these supply the lateral thalamus, specifically the VPM and VPL, so body and face sensation, and the lateral geniculate nucleus for vision. And this is where the classic exam question comes in, where they say a lesion here gives you a contralateral sensory loss, body and face, often with visual deficits layered on top. So compressing that framework, right, we have PCA for deep vasculature, we have thalamus heavy strokes, right? So you have medial, which are going to be your thalamo-perforator arteries, and that should be consciousness and eye movement. Then you have thalamo-geniculate arteries, which will be your lateral thalamus, and that's going to be sensory loss from your VPM and VPL, and maybe a little bit of vision, depending on the lesion. Then you have your posterior choroidal, which are just for memory and thalamic association deficits. So if you see a patient, let's say with contralateral sensory loss and a weird burning pain later, that's going to be pointing you towards a PCA thalamic stroke, VPL to VPN, right? You want to be thinking thalamic pain syndrome for that. If instead the stem emphasizes confusion or decreased alertness, you want to be thinking medial thalamus. So that would be your thalamo-perforators. So I wouldn't really recommend memorizing every branch and more recognizing the presentations associated with each stroke. All right, so here we have one of the highest yield small artery, big consequence vessels in neuro. So we have the anterior choroidal artery, which again comes off that ICA and runs along the optic tract into the temporal horn, which is a useful anatomical clue. So anything along that path is fair game for this injury. So what supplies it is the key here. So if it hits the posterior limb of the internal capsule, which carries, again, those corticospinal motor fibers, the optic tract and the lateral geniculate body, the lagoon, right, our vision pathway, and also limbic and basal ganglia structures like the hippocampus, globus pallidus, and tail of the caudate. This artery uniquely is going to be combining motor, vision, and memory emotion territories, okay? So because of that mix, the classic lesion pattern is really predictable. You get contralateral motor weakness from the internal capsule, contralateral sensory involvement can occur, and importantly, you get visual deficits, classically a homonymous hemianopia from involvement of that optic tract and LGN. And this is why people summarize it as a triad. You get the motor, sensory, and visual, even if sensory isn't always prominent. And here, like I said, I have a big high yield just overview slide. If you need to just very briefly review it, I honestly recommend just copying and pasting this into whatever search engine or tool you're using to study, and then just study the strokes associated with each of these and just remember those patterns, and you should be pretty okay. Again, I really don't recommend just memorizing every single structure that it innervates, because you're not a computer, right? You're only human. So it's all about pattern recognition with these guys. All right, so now we're kind of shifting gears. So now we're going to go into the hierarchy of autonomic control, and it's a little simpler than it looks, okay? So the brainstem is basically the core life support center, right? It runs breathing, heart rate, reflexes, and things like micturition, which is going to the bathroom, peeing, automatically. So you don't consciously control most of this. This is why brainstem damage is immediately very dangerous. Within the brainstem, the medulla is the primary rhythm generator, especially for breathing. So it contains the fundamental circuits that produce the baseline respiratory system. If the medulla is severely damaged, you lose the ability to basically generate a stable breathing rhythm altogether. The pons sits on top of that and fine-tunes the rhythm. So it doesn't create breathing from scratch, it adjusts the timing, it's smoothing transitions between inspiration and expiration, so it's more like an editor of the medulla's just raw signal to breathe. Damage here doesn't stop breathing completely, but it makes it abnormal and irregular. Then you have chemoreceptors, which act as feedback regulators, and they monitor things like carbon dioxide, oxygen, pH levels, and adjust the respiratory drive accordingly. So if carbon dioxide rises, they push the system to increase ventilation because you're trying to get rid of it. So they're not generating the rhythm, they're constantly tuning output based on the body's needs. So medulla is like the engine, right? It makes the rhythm. The pons is the tuner. It refines that rhythm. And the chemoreceptors are just sensors, and they adjust it based on the chemistry. All right, and now we're doing a deep dive into the medulla. And this is just how it actually generates and scales that breathing. So it has the dorsal respiratory group, or the DRG, and that's going to be your baseline system. It sits in the medulla and sets the basic inspiratory rhythm. And this is quiet, automatic breathing when you're just sitting around, right? It constantly is receiving sensory input from cranial nerve 9 and 10, which bring in information from peripheral chemoreceptors, that sense oxygen, carbon dioxide, and pH, and lung stretch receptors. And based on that input, the DRG sends output down the phrenic nerve to the diaphragm, driving inspiration. So functionally, DRG is the inhale generator and sensory integrator. The ventral respiratory group, the VRG, is different. It's mostly silent at rest, but it kicks in when you need increased ventilatory demand, right? So like exercise or respiratory distress. So when it's active, it recruits accessory muscles and helps drive active expiration, which normally doesn't require effort. So VRG is basically like the backup system for high demand breathing, okay? So DRG, just remember, is that quiet breathing, inspiration, diaphragm. It's docile, DRG, okay, using the phrenic nerve. Then VRG, very, very strong breathing, and that's going to be forced breathing, expiration, and you're using accessory muscles. So someone's normal resting breath, DRG driven. If the vignette mentions labored breathing or accessory muscle use or forced expiration, that's going to be your VRG stepping in and helping out. All right, so this is going to be that fine-tuning layer of breathing that sits on top of the medulla. So the Pontine respiratory group, or the PRG, doesn't generate breathing, right? That's the medulla's job. We just talked about that. Instead, it shapes the pattern, mainly by controlling how long inspirations last. So in the rostral pons, or the superior pons, you have the pneumotaxic center, which acts like a cutoff switch for inspiration. It limits inspiratory time, so breaths become shorter and more frequent. If this area is more active, you get faster, shallower breaths because inspiration is being terminated early. In the caudal pons, you have the apneustic center, which does the opposite. It promotes and prolongs inspiration, encouraging deeper, long breaths. If this influence dominates, inspirations are held longer, leading towards the classic apneustic pattern, which is prolonged inspiratory pauses. So the balance between these two determine the rhythm's quality. So the pneumotaxic or rostral, right, they cut it off. It shortens breath, so it increases that rate. I like to think taxis go fast in New York, so they're trying to go fast. You're trying to increase your breath rate, right? Pneumotaxic, okay? Then you have the apneustic, and apneustic is keep going, longer breaths, decreasing that rate. Like, I like to think of like a yogi, right, named apneustic, who's running like a meditation class, and he's like, oh, my name's apneustic, guys, and we're going to take a deep breath. That's going to be your apneustic guy. And he's in the caudal pons because, you know, we all know that yoga instructors like to sit crisscross applesauce on a map, right? So they're going to be lower, okay? So apneustic is going to be in that caudal pons, and pneumotaxic is going to be rostral, okay? All right. And again, we're just going to cover some lesions of the stuff we just learned. So medullary region, right? This is catastrophic because the medulla is that rhythm generator. If you damage it, you lose the ability to produce a stable breathing pattern at all, and you get ataxic breathing, which is completely irregular, unpredictable breaths with pauses. It's not just abnormal, it's just not functional, which is why it quickly progresses to respiratory failure and eventually death. A Pontine lesion, on the other hand, doesn't eliminate breathing, it just distorts it. So specifically, if you lose the pneumotaxic center in the rostral pons, you remove the cutoff signal that normally limits inspiration. And that leaves the apneustic center in the caudal pons, which is unopposed. So inspirations become prolonged and held, and the result is apneustic breathing. So deep, gasping inspirations with pauses before expiration. I don't know if anybody has seen Malcolm in the Middle, and I'm totally forgetting his friend's name, but it's the kid, I think his name's Stevie. I want to say it's Stevie. It might be Stevie. I haven't seen that movie since I was like 7 or 10 or something. But Malcolm in the Middle, they have a character that has this exact type of breathing pattern. It's like his best bud. Yeah, I don't. That just popped into my head as I was recording. I just need to bring it up. But yeah. So basically, medulla lesion, no rhythm, chaotic is, it's going to produce ataxia and eventually become fatal. Pons lesion, you have no modulation of that rhythm, so you're going to have prolonged inspiration and you're going to have an apneustic pattern. So if a question is describing irregular breathing with no pattern, you want to think medulla. If it describes a long inspiratory holds or a stuck inhalation, you want to be thinking pons. All right, so this slide is about a paired system, sensory in and motor out. And it's going to be part of a reflex that we'll cover later, but basically, the first component is the Nucleus, tractus, solitarius. And it's the main visceral sensory hub of the brainstem. It collects incoming information from cranial nerves 7, 9, and 10. The rostral portion handles taste, while the caudal portion monitors internal body status, things like chemoreceptors, baroreceptors, and visceral signals from the cardiovascular, respiratory, and GI systems. So functionally, the NTS is constantly answering the question, what is going on inside the body right now? Remember, this is our Nucleus solitarius, right? He's our really picky chef. He does taste, and he wants to know what's going on inside the body. So that information doesn't just sit there, right? It gets relayed to motor nuclei, especially the nucleus ambiguus. And so the nucleus ambiguus is the motor nucleus of cranial nerve 9 and 10 that sends output to muscles of the pharynx and larynx, and also contributes to parasympathetic control of the heart. So it controls swallowing, speech, and vagal cardiac output, so heart rate slowing. Put together, this creates a reflex loop. The NTS receives sensory input, processes it, and then signals the nucleus ambiguus to generate the appropriate motor response. A classic example is the baroreceptor reflex. So increase in blood pressure, signals travel via cranial nerve 9, 10, to the nucleus tractus solitarius. Then the nucleus tractus solitarius activates the nucleus ambiguus, and that will increase vagal output, and that will cause your heart rate to decrease. So sensory in, motor out. And here is just a slide that basically summarizes all the big reflexes to know here regarding this system, at least. There are others that we have covered in other ones, but just within this scope. So most brainstem reflexes follow the same wiring template, right? So everything revolves around the nucleus tractus solitarius here as the sensory hub and the nucleus ambiguus plus that vagus output as the motor response. So starting with the baroreceptor reflex, since it's the highest yield, right? So increase in blood pressure activates stretch receptors in the carotid sinus and the aortic arch, and that's going to send signals through cranial nerve 9 and cranial nerve 10 to the nucleus tractus solitarius. The nucleus tractus solitarius then activates vagal output via nucleus ambiguus, which slows the heart rate, okay? So the logic is high pressure, more firing, more vagus, lower heart rate. Then all you do is just flip it for low blood pressure. Less input to the nucleus tractus solitarius means less vagal tone and relatively increased sympathetic activity, so your heart rate's going to go up. The gag reflex is constant, right? We've talked about it since Neuro week 1. So sensory is going to be afferent coming in through cranial nerve 9, which detects the touch in the posterior pharynx, and it's going to send it to that nucleus tractus solitarius. Then the motor, the efferent part of it, is going to be cranial nerve 10, which activates pharyngeal muscles. If someone has no gag, when you touch the right side, you can localize whether it's 9, the sensory side of things, or the afferent side of things, or 10, right? The motor side of things, depending on what is failing. The cough reflex is simpler because both afferent and efferent limbs are just going to be 10. So irritation in the airway sends vagal sensory input to the nucleus tractus solitarius, and that's going to drive vagal motor output to produce the cough. The sneeze reflex is a little different. It uses cranial nerve 5 as the sensory limb, which makes sense because that's, your face is 5 sensory territory. And that's going to cause nasal irritation, but still ultimately feeds into brainstem respiratory centers to produce that motor pattern. And so the unifying concept is this, right? Is that afferent nerve is going to go to that nucleus tractus solitarius, then it's going to go to nucleus ambiguus and vagal output for that motor response or efferent response. So just remember that nucleus tractus solitarius is sensory integration, and ambiguous and vagus are going to be that motor output. And you can reconstruct most of these. All right, so while we're on reflexes and stuff, we're going to cover some herniations here. So this is one of those topics, again, you want to know the pattern with these, okay? So it's about mechanical compression leading to a testable pattern. So start with the tonsillar herniation, right? And these aren't your mouth tonsils, these are tonsils of the cerebellum. So the cerebellar tonsils get pushed downwards through the foramen magnum and directly compress the medulla. And that's the key. The medulla runs breathing, right? Heart rate and basic life reflexes. So when it gets compressed, you get respiratory arrest, loss of consciousness, and rapid death. It's just basically lights out. Now comparing the uncal herniation, which is more stepwise and very testable. So the medial temporal lobe, the uncus, gets pushed downward through the tentorial notch, and the first structure it hits is cranial nerve 3, the ocular motor nerve. The parasympathetic fibers controlling the pupil constriction are superficial on cranial nerve 3, so they get compressed first, and that's why the earliest sign is a blown pupil, dilated, non-reactive on the same side. As the herniation worsens, it compresses the midbrain, including descending motor pathways, like the corticospinal tract. So that gives you contralateral weakness. So the classic pattern becomes ipsilateral blown pupil and contralateral hemiparesis. Okay, and a little bit of a flashback to GI renal. But this is basically the flip the switch system of, whether you're going to be holding in your pee or you're going to be peeing. So starting with the hierarchy, the cortex is basically the social control. It keeps you from peeing yourself in a public space, right? The Pontine micturition center is the coordination that flips between storage and voiding. And then the spinal cord is what executes the reflex. So now let's think of the two opposing states. We have during storage, or the filling phase, the body is trying to hold in urine, right? So everything that promotes retention is on. So the sympathetic system relaxes the detrusor muscle and contracts the internal sphincter. The pudendal nerve, which is under somatic innervation, keeps the external sphincter contracted. Meanwhile, the parasympathetic system is off. So the bladder isn't squeezing. So the net effect is that the bladder fills quietly without leaking. And the way I like to remember that sympathetics help you store your bladder by relaxing a muscle, which I know is a little counterintuitive because we always think of sympathetics as contracting things and whatnot. But I like to think of it as remember, parasympathetics are your rest and digest. Digesting has to do with going to the bathroom, right? So parasympathetics are going to make you want to pee, whereas sympathetics are doing the opposite of that, which is don't pee, right? You're running away from the bear. So during voiding, okay, everything flips. The goal is to empty the bladder efficiently, right? You're trying to pee it all out. And so the parasympathetic system turns on, causing detrusor contraction. So the sympathetic system turns off, so the internal sphincter relaxes, and then the pudendal nerve turns off, relaxing the external sphincter, and the net effect is a coordinated contraction in sphincter relaxation and urination. So starting with the normal setup here, okay, we're just going to look at lesions, right, that affect your bladder. So with the S2 to S4 spinal cord, that's going to contain the reflex arc, so parasympathetic outflow that contracts the bladder. Then you have the brain, which is going to be the cortex and the Pontine micturition center, the PMC, and that's going to sit on top and control / inhibit this reflex, okay? So now let's split the lesions into two buckets, right? We have the upper motor neuron lesion, which is going to be above that S2 to S4. So the spinal reflex is still intact, but you cut off brain control. So the bladder becomes hyperactive and reflexive. And this is very similar to our muscles, right? Like if you lose upper motor neuron control, right, you're going to get spastic movements, okay? But if you hit a lower motor neuron, right, it's going to be atrophy and fasciculations, okay? So this is following the exact same pattern. So if you have an upper motor neuron lesion, so above S2 to S4, that's going to give you your spastic bladder. So that's going to be small capacity, frequent urination, urgency, and incontinence. You have no breaks, so you're going to start peeing like crazy, right? Then with the lower motor neuron lesion, which will be at the levels of S2 to S4, you have destroyed the reflex itself. So the parasympathetic system can't contract the detrusor muscle, so your bladder just fills and fills and fills without emptying. So that gives you a flaccid bladder. It's large, it's distended, no contraction, and eventually overflow incontinence. And it's going to be dribbling because it's too full. So again, this maps pretty cleanly onto that upper motor neuron versus lower motor neuron lesion that we've seen in every other example of upper motor neuron and lower motor neuron lesions. Okay, so now we're moving on to big picture map of movement. So movement is one structure. Movement isn't one structure doing a job, right? And I hope you know that by now. So it's looped systems with roles, right? So the cortex is basically the big boss, right? It decides what you want to do and sends that command down through the corticospinal and corticobulbar tracts to actually execute that movement. But the cortex doesn't act alone, right? It constantly checks with two major advisors. The basal ganglia handle action selection, so think of them, right, as filtering options. They help choose the correct movement and suppress competing ones. So if they fail, you either get too little movement, which is Parkinson's, or too much uncontrolled movement, and that's Huntington's. The cerebellum is the quality control system. It compares what you intended to do with what you're actually doing and makes real-time corrections. That's why the cerebellar lesions give you ataxia, not weakness, but just sloppy, uncoordinated movement. The thalamus is the relay hub that sends all this processed information back to the cortex so the loop can continue. So the big loop is essentially cortex to the basal ganglia / cerebellum, to the thalamus, then to the cortex. Now the key concept here is the efferent's copy. Not coffee. Oh my gosh, maybe I need some coffee. But basically what an efferent's copy is when the cortex sends a motor command to your muscles, it sends a copy of that same command into the brain, especially to the cerebellum. And this copy is used to predict what should happen if the movement goes correctly. And this is how your cerebellum knows to make correction in real time, because it has the blueprints of what your brain wanted to do with your muscles. So then your brain basically compares what it expected to feel, which is like prediction, and then versus what it actually feels, which would be that sensory feedback. And if there's a mismatch, the cerebellum corrects it on the fly. So this is why you can't tickle yourself, right? Your brain already predicted the sensation using the efferent's copy. You knew that it was coming, so you're not going to have a huge response to that. External stimuli don't have that prediction, so they feel stronger, right? Because you're not making decisions for other people. And if you are, you should maybe go talk to a therapist. I don't know, man. That sounds like a problem. But in short, yes, this is just, if this all is starting to feel like review, that's a good thing. That means you know your stuff, right? Okay, this is just us basically taking all the little tiny bits and pieces that we've talked about separately and throwing them all into one big area now. All right, and now we're going to focus on the prediction aspect of the cerebellum, right? So when you decide to move, the cortex sends the command. Remember, the cerebellum doesn't wait to see what happens, right? It generates a feed-forward prediction of what that movement should feel like before it's even started. And that prediction is built using that efference copy that it got from the cortex. It's like the preview. It's basically showing the cerebellum like a trailer of the movement that it wants to make, and then the cerebellum's waiting for like the actual movie to come out, and it's going to compare it. Once the movement actually begins, real sensory feedback comes in. So that's through proprioception, vestibular input, whatever. Now the cerebellum switches into feedback mode, comparing what actually happened to what was predicted with that efference copy. So if there's a mismatch, it sends correction signals back through the thalamus to the cortex to fine-tune the movement in real time. So instead of thinking of feed forward versus feedback as separate systems, think of them as just a prediction first and then sending corrections. So the core function is that it's comparison, right? It's the expected outcome versus the actual outcome, and then error signals, and then correction. And that's why the cerebellar lesions don't cause weakness. They cause inaccuracy. You basically don't have someone double checking all your movements anymore. So that's why you'll see things off target. You'll be a little delayed. You'll have ataxia. You'll have an intention tremor, because the brain can't properly predict or correct your movements. So the pathway at the bottom here is just a cerebellar loop here, and it's worth spending some time with it just to understand it. The cortex again sends that plan to the Pontine nuclei, which relay it to the cerebellum via the middle cerebral peduncles, and the cerebellum processes that information, then outputs through the deep nuclei, and sends signals to the thalamus and then back to the cortex to adjust the movement. So the loop goes cortex to the pons, cerebellum to the deep nuclei, to the thalamus, then back to the cortex. Okay, so big picture, cortex is the command center, cerebellum predicts the movement and fixes the command, and the loop is just constant refinement. All right, and this slide is going to be tying the cerebellum to where its corrections actually go and what happens when that system breaks, which we've kind of touched on with the lesions, but like I said, repetition is the key to mastery, right? So think of the cerebellum as producing that correction signal, right? So that signal has three main destinations, each explaining a different clinical feature. So the biggest output is to that thalamus, which then projects back to the motor cortex. And this is how the cerebellum fine-tunes voluntary movement. If this pathway is off, the cortex still sends commands, but they're just poorly adjusted movements. We've been over that. The cerebellum also projects to the red nucleus, which helps with limb adjustments, especially during ongoing movement. So this is more about refining arm and distal limb control while you're already moving. Finally, it connects to the vestibular nuclei, which handle balance and eye movements. And that's why cerebellar problems often show up as gait instability and abnormal eye movements, like nystagmus, and not just limb issues. So cerebellar lesion, right, is leading to prediction failure. And that's going to be the underlying concept here. The brain can still generate movement, but it's just going to be really poorly coordinated movement, all right? So again, you'll be seeing things like gait instability, ataxia, intention tremor, and a high yield detail to always keep in mind is that cerebellar deficits are always ipsilateral because of double crossing in the pathway. A lesion on one side affects movement on the same side of the body. So it does decussate, but it does it twice, so the problem is still ipsilateral. Or like the effects of a lesion will still be ipsilateral. Okay, and this is just going to be a big slide comparing the role of basal ganglia and the cerebellum, because I think it could be really easily confused, so I just wanted like a clear big picture thing here, looping around to both of them and just comparing the two directly. So starting with the simplest distinction, right? The basal ganglia decide whether a movement happens, while the cerebellum determines how well it happens. The basal ganglia act before the movement happens, and they take all the possible motor plans from the cortex and suppress the wrong ones so the correct movement can go through. It's a selection and filtering system. That's why their core mechanism is inhibit competing plans to allow the right one. The cerebellum acts during the movement, right? It doesn't choose the movement, it monitors and adjusts it in real time. It compares the expected, which it got from that efference copy, versus the actual movement, which it senses through sensation, and sends correction signals in real time. And that's why the mechanism is prediction and error correction. So if you just think of the terms as basal ganglia are the planning and cerebellum is that execution and real-time correction, you're all right. Looking at pathology, right, so applying this to exam content, When the basal ganglia are damaged, the issue is with movement selection. So you're going to get either too little movement, like with Parkinson's, so bradykinesia, or you're going to get too much movement. So that's going to be like Huntington's, okay? So basal ganglia problems are going to be the wrong amount of movement. Whereas when the cerebellum is damaged, right, when we've talked about it a lot, right, I'm beating a dead horse at this point, but it's ataxia, intention tremor, dysmetria, which is going to be past pointing, where you go past what you intended to grab. So cerebellar problems are like that wrong quality of movement. And again, that efference copy is the distinction between the two, right? So the basal ganglia use past experience and reward to help decide which movement to choose, which is why you eventually get better at different things that you keep practicing over and over again. Like if you're doing a handstand or a cartwheel or whatever, it remembers those errors and it learns from that. Like sure, muscles play a role in being able to stabilize you a little better, but also the basal ganglia are also learning on how to make that better by limiting the movements that you're putting out there. And the cerebellum uses the efference copy to predict sensory outcomes and adjust the movements on the fly. So again, basal ganglia are that gate movements, that on and off decision of whether or not a movement is happening in the first place. And the cerebellum is, let's refine it now that movement is happening. All right. I know this is a lot of repetition, but this stuff can get really confusing the more we get into it. So I'm just trying to keep these separate, okay? So the vestibular system is essentially your brain's internal level and motion sensor. Its job is to keep three things stable at all times: your gaze, your posture, and your sense of where you are in space. And it works tightly with the cerebellum, which fine-tunes those responses. So everything starts with the inner ear receptors. The semicircular canals detect rotation, which will be angular acceleration, while the utricle and saccule detect linear acceleration and head positioning. So the information travels via cranial nerve 8 to the vestibular nuclei in the brainstem, which act as the central processing hub. From there, the system splits into three functional outputs. And this is the part to really lock in here. So first, to the eyes via the vestibulo-ocular reflex, or the VOR, and this stabilizes your gaze. If you turn your head left, your eyes automatically move to the right to keep your vision fixed. And when that system is off, you get nystagmus, right? And that involves that MLF, and we talked about it all with week 3 stuff. Second, you have the spinal cord via the vestibulospinal tract, and this controls posture and balance by adjusting muscle tone, especially in extensor muscles. And when it's disrupted, you get falling or leaning to one side. And then you have the third one is the cortex via the thalamic pathways. And this gives you the consciousness perception of motion and orientation, basically knowing that you're spinning or tilting. So just remember that input, right, is that inner ear. The processing happens in the vestibular nuclei, and the outputs are going to be in the eye for that vestibular ocular reflex, posture for the spinal, and perception for the cortex. And so the issues will follow that. So you're going to have eye issues will be nystagmus, postural issues will be imbalance and falling, and perceptional issues will be vertigo. All right, and we're going to be revisiting our ear structures just because we're tying more neurology into this, okay? So again, just a little bit of review from the previous slides. Remember, the bony labyrinth contains perilymph and sits inside that membranous labyrinth, which contains endolymph. And the key distinction is functional, right? Endolymph is what actually bathes the sensory hair cells and drives signaling. You don't need ion details here. Just remember, endolymph is the active fluid, right? Next is the endolymphatic sac, which is basically the system's pressure regulator. It maintains fluid volume and ionic balance. If it malfunctions, endolymph starts to build up, and you get something called Meniere's disease, or endolymphatic hydrops. And that's where the classic symptoms start to form. So you're going to have vertigo, which is because your vestibular system is disrupted. You're going to have tinnitus, which is abnormal auditory signaling. You'll have hearing loss, which is cochlear involvement. And then you'll have oral fullness, which is pressure sensation. So if you see that combo, that's Meniere's, okay? Finally, the blood supply is very high yield here. So the inner ear, again, is supplied by the labyrinthine artery, usually from the aica, and it has no collateral circulation. So that means if it gets blocked, the inner ear goes down immediately. So ischemia gives you sudden hearing loss and vertigo. And that combination is a red flag for aica/labyrinthine artery involvement, right? So clinically, it helps distinguish vascular causes from the more benign vertigo. All right, so Endolymph, remember, is that functional fluid. Endolymphatic sac is that pressure control, and if it fails to do its job, you get Meniere. Aica and the labyrinthine artery have no collateral, so basically no backup blood flow. So if they infarct, you're going to get sudden hearing loss and vertigo. All right, so again, as we get towards the end of neuro here, a lot of this stuff is going to start to feel like review because we're basically combining everything we've learned, okay? Okay, so this slide is essentially just going to be walking you through how vestibular information from cranial nerve 8 enters the brain and gets distributed to control balance, eye movements, and spatial awareness. The vestibular ganglion contains the primary sensory neurons, which receive input from 3 main structures in the inner ear. The semicircular canals detect rotational movement of the head. Now remember that because semicircular circles are rotational, right? So there you go. Semicircular canals detect rotational movement, while the utricle detects horizontal linear acceleration. I remember that one because utricle starts with a U, and Uber is a car. It drives horizontally. So utricle, horizontal linear acceleration. And then the saccule detects vertical acceleration. And I remember saccule, like scaffolding going up, so vertical. Okay? Together, these structures allow the brain to understand both motion and position in space. That information is carried into the brainstem and synapses in the vestibular nuclei, which sit along the floor of the fourth ventricle. And there are 4 nuclei. You have the superior, the medial, the lateral, and the inferior. But rather than just memorizing them in isolation, it's more useful to think about them how they functionally are organized. So inputs related to rotation from the semicircular canals primarily go to the superior and medial nuclei, which are heavily involved in coordinating eye movements. In contrast, Inputs related to position and gravity from the utricle and saccule are more associated with the lateral and inferior nuclei, which contribute more to posture and balance. From the vestibular nuclei, signals are distributed along several key pathways, and one major pathway projects to the cortex through the thalamus, allowing conscious perception of motion and orientation, which is why vestibular dysfunction can produce the sensation of vertigo. Another pathway goes to the cerebellum, where ongoing movement is continuously adjusted to maintain balance and coordination, and this is part of that broader cerebellar role in comparing expected versus actual movements and correcting those errors in real time. A third critical output is to the ocular motor nuclei, cranial nerves 3, 4, and 6, via the medial longitudinal fasciculus, that MLF. And this pathway drives the vestibulo-ocular reflex, which again stabilizes the gaze during head movement. Finally, projections descend to the spinal cord through the vestibulospinal tracts, and these pathways adjust muscle tone and posture to maintain balance, particularly during changes in head position and movement. And this is why vestibular lesions often lead not only to dizziness, but also to instability while standing or walking. So taken together, the vestibular system is constantly integrating sensory input and distributing it to multiple targets. It allows you to perceive motion, stabilize your vision, and maintain posture simultaneously. When any part of the system is disrupted, the result is a combination of vertigo, abnormal eye movements, and impaired balance. So the cerebello-pontine angle, or the CPA, is clinically important space located between the pons and the cerebellum. And it's not just an anatomical gap, right? It's a crowded intersection where several key neurovascular structures are going to pass. So the most important thing that runs through the CPA are cranial nerves 7, facial nerve, and 8, which is vestibulocochlear nerve, alongside aica, the anterior-inferior cerebellar artery. Because these structures are tightly packed together, anything that grows in this space tends to affect them together rather than in isolation. So the classic pathology here is the vestibular schwannoma, a benign tumor arising from Schwann cells of cranial nerve 8. It typically originates from the vestibular portion of the nerve and grows slowly, which means symptoms often develop gradually and in a predictable sequence. The first symptom is usually unilateral hearing loss because cranial nerve 8 is affected early. As the tumor enlarges, it begins to compress the facial nerve, leading to the facial weakness on the same side. With further growth, nearby structures start to become involved, including the trigeminal nerve, which causes facial numbness because the tumor sits right next to the cerebellum, so patients can also develop ataxia due to cerebellar compression. So the key pattern to recognize is that this is a multi-cranial nerve lesion in a very specific location. So if you see a question describing progressive unilateral hearing loss followed by facial weakness and then balance issues, you should immediately be thinking of that cerebello-pontine angle lesion, and most likely a vestibular schwannoma. All right, so now we're going to be tying together brainstem motor pathways with coma posturing, which is something exam questions are going to love to kind of throw into vignettes. So the key idea is that movement is not just controlled by the corticospinal tract. There's also indirect descending pathways from the brainstem that set the baseline tone of the body, especially the balance between flexion and extension. The rubrospinal tract promotes flexion, primarily in the upper limbs. The vestibulospinal tract promotes extension, especially for maintaining posture and standing upright. The reticulospinal tract helps regulate overall posture and tone, and under normal conditions, these systems are balanced and are modulated by cortical input. When you lose cortical control, these brainstem pathways become basically unregulated, and whichever pathway is still intact starts to dominate, and that's what produces this abnormal posturing. In decorticate posturing, the lesion is above the level of the red nucleus, typically in the cerebral hemispheres or internal capsule. Because the red nucleus is still intact, the rubrospinal tract continues to drive flexion in the arms. At the same time, the vestibulospinal tract is still promoting extension in the legs, so the result is flexed arms and extended legs. And a useful way to think about it is that cortical control is gone, right? But the red nucleus is still active, so flexion of the upper limbs is preserved. The also way I like to remember that the lesion is above the red nucleus is that your arms go up and in, right? And if you're going up, then the lesion is above the red nucleus, okay? In decelerate posturing, the lesion is at or below the level of the red nucleus, usually in the midbrain or upper pons. And now the rubrospinal tract is lost, so there's no flexion signal. The vestibulospinal tract dominates completely, leading to extension in both the arms and the legs. And this is why decelerate posturing is all extension. Clinically, this is more concerning because it reflects a lesion deeper in the brainstem. So the distinction comes down to one question, right? Is the red nucleus still functioning? If yes, you get those flexed arms. And if no, extension basically takes over everywhere. Okay, and the little graphic here is really nice because it uses a nice little way to remember them. Is that if your arms are like C's, then it's moving towards the cord, so that's going to be a decoricate posturing. And then if they're out, your hands look like E's, so then it's going to be decelerate posturing, and that's going to be extensors are dominating there. All right, so basically now we're just adding clinical correlates to what we just described. So again, starting with that dorsal midbrain, this region controls vertical gaze and pupillary reflex integration. So when it's damaged, you get Paronod syndrome. The hallmark is loss of upward gaze because the vertical gaze centers are disrupted. You also see convergence, retraction, nystagmus, and problems with pupillary light reflex. The classic cause is a pineal tumor, which makes sense anatomically because the pineal gland sits just above the dorsal midbrain and compresses it downward. Moving ventrally, you're now in the territory of major motor tracts and the ocular motor nerve as it exits. And this produces the Weber syndrome pattern. The corticospinal and corticobulbar tracts are hit, leading to contralateral weakness of the body. And at the same time, cranial nerve 3 is affected before it exits, giving you ipsilateral ocular motor palsy with a dilated pupil. This combination, ipsilateral cranial nerve 3 deficit with contralateral body weakness, is an example of those crossed findings that we were just talking about that would confirm a brainstem lesion. In the central midbrain, the key structure is the red nucleus. So damage here still affects cranial nerve 3, but now you know also it will disrupt motor coordination pathways instead of just pure weakness. So you see contralateral ataxia or tremor, and this reflects a loss of fine motor control rather than loss of strength, which is an important distinction when you're reading a vignette, right? And finally, you have lateral midbrain lesions, which involve sensory pathways like the spinothalamic tract and that HRST, or those descending sympathetic pathways. And this produces contralateral loss of pain and temperature sensation along with ipsilateral Horner syndrome. And that combination with sensory loss plus autonomic dysfunction is a strong clue that you're in the lateral brainstem. Okay? So again, a way to approach this is just systematic. First, confirm you're in the brainstem with those crossed findings. Ask what type of deficits are dominant, right? Eye movement problems point you dorsally. Pure motor weakness points you ventrally. Coordination problems point you centrally, and sensory plus autonomic findings point you laterally. All right, so now we're going to be doing the same thing, but now with the pons, okay? We're just recognizing patterns here. So starting with the medial Pontine syndrome, you should think about structures that run through the medial pons. And this includes the corticospinal tract, which explains the contralateral body weakness, and the medial lemniscus, which carries fine touch and proprioception, giving contralateral sensory loss. And in addition, cranial nerves 6 and 7 are affected on the same side as the lesion. So you get ipsilateral deficits involving eye abduction, which is cranial nerve 6, right, abducens, and facial movement, which is cranial nerve 7, facial nerve. And this combination leads to ipsilateral cranial nerve deficits with contralateral body findings, again being that classic example of the contralateral findings. So a clinical correlate here is locked-in syndrome, which is a special case and one of the most important to recognize clinically. It's a result from bilateral damage to the ventral pons, usually affecting the corticospinal and corticobulbar tracts. And the cortex itself is intact, so the patient is conscious and aware, but they cannot move their body, resulting in quadriplegia. The key rule is that the vertical eye movement is what's preserved here, because those pathways run outside of this damaged region, okay? So the patient can often communicate only by moving their eyes up or down. Lateral Pontine syndrome shifts you to a different set of structures. Instead of motor tracts and medial lemniscus, you're now affecting pathways like the spinothalamic tract, which produces pain and temperature, right? And you also hit cranial nerve nuclei in this region, especially 5 and 7, leading to facial sensory deficits or facial weakness on the same side. Because the cerebellar connections pass nearby, you often see ipsilateral ataxia as well. So the pattern here is ipsilateral facial and coordination issues with contralateral pain and temperature loss. Okay? So the way to approach the Pontine lesions, again, is the same structured method. Identify you're in the brainstem with those contralateral findings. Decide whether the pattern is medial, right? So that'd be motor weakness and fine touch loss, or lateral, pain and temperature loss with cranial nerve and cerebellar involvement. And if the presentation is so extreme with preserved consciousness but no movement, think immediately of that bilateral ventral lesion and locked-in syndrome. All right, so this slide is the final step in the pattern, right? We've done midbrain, we've done pons, and now we're doing medulla. So in the medial medullary lesion, also called de Giorni syndrome, you are hitting structures that run close to midline. The cortical spinal tract is going to get affected, so you're going to get contralateral body weakness. The medial lemniscus is also involved, which causes contralateral loss of proprioception and fine touch. The cranial nerve here is cranial nerve 12, the hypoglossal nerve, which controls tongue movements, because the cranial nerves are affected before crossing. You're going to get ipsilateral tongue deviation, right? That tongue deviates towards the side of the lesion because that side is weak. Okay, so that pattern is ipsilateral tongue deviation with contralateral motor and proprioceptive deficits. In contrast, a lateral medullary lesion, known as Wallenberg syndrome, affects a completely different set of structures. Instead of corticospinal tract and medial lemniscus, you're now going to be hitting spinothalamic tract, which gives you contralateral loss of pain and temperature from the body. At the same time, the spinal trigeminal system is affected, causing ipsilateral loss of pain and temperature in the face. And this is a key crossed sensory pattern specific to lateral lesions. Additional findings come from nearby structures, right? So the nucleus ambiguus is involved, which controls swallowing and parts of speech via cranial nerve 9 and 10. So patients develop dysphagia and hoarseness. The cerebellar connections are also affected, so leading to ipsilateral ataxia. And finally, descending sympathetic fibers are disrupted, producing ipsilateral Horner syndrome. Okay, so the way to recognize Wallenberg is by stacking these features together. So ipsilateral facial pain and temperature loss, contralateral body pain and temperature loss, plus dysphagia, ataxia, and Horner syndrome. And that cluster is going to be very specific. So at a high level, medial lesions give you motor weakness and fine touch, proprioception loss, along with cranial nerve deficits. Lateral lesions are going to give you pain and temperature problems, autonomic findings, and coordination issues. And if you keep that framework in mind, you can localize most of the brainstem issues. All right, now moving out of the brainstem, just closing it out with the spinal cord. Okay, so in the spinal cord, the key to localization is knowing where tracts cross. The corticospinal tract and dorsal columns, which carry proprioception and fine touch, right? That dorsal column, medial and lemniscal tract, have already crossed up in the brainstem. So that means that when they are damaged in the spinal cord, the deficits appear on the same side of the lesion. So you get ipsilateral motor weakness and ipsilateral loss of proprioception below the level of the lesion. Pain and temperature behave differently because of the spinothalamic tract, which crosses almost immediately after entering the spinal cord. So typically within 1 to 2 levels. Because of this early crossing, a lesion on one side of the cord produces pain and temperature loss on the opposite side of the body, and that's why the pattern is ipsilateral motor and proprioception loss with contralateral pain and temperature loss. Syringomyelia represents a different type of spinal cord lesion because it affects a central portion of the spinal cord rather than just one side. The expanding central canal basically disrupts the crossing fibers of the spinothalamic tract right at the level where they decussate. Remember, because pain fibers decussate immediately. And since these fibers are responsible for pain and temperature sensation, the result is a bilateral loss of pain and temperature in the affected dermatomes. So because this often occurs in the cervical region, it produces the classic cape-like distribution over the shoulders and upper back. So the key distinction is that hemisection gives you a clean left and right split, while central lesions like syringomyelia, selectively knocks out crossing fibers, producing a symmetric sensory loss without the motor and proprioceptive findings you would expect to find from a lateralized lesion. All right, and again, just to have it all in one place, there's going to be just some fast clinical correlates, okay? High yield stuff. So again, CPA tumor, classically a vestibular schwannoma. It hits structures in a predictable order because of how tightly packed that space is. So cranial nerve 8 goes first, so hearing loss is usually the earliest finding. As the tumor grows, it starts to compress cranial nerve 7, giving you facial weakness, and then cranial nerve 5, leading to facial numbness. If you see progressive unilateral hearing loss plus facial symptoms, you want to be thinking CPA tumor immediately. A pineal tumor lives in the dorsal midbrain and disrupts vertical gaze centers, producing Paranod syndrome. The hallmark is the inability to look up, often with pupillary abnormalities. If the question mentions upward gaze palsy, you shouldn't even finish reading that stem and just pineal tumor, okay? Pituitary tumor compresses the optic chiasm from below, selectively hitting crossing nasal fibers, and that gives bitemporal hemianopia, so loss of peripheral vision in both eyes, plus endocrine dysfunction. So vision plus hormones, that's going to be your pituitary tumor until proven otherwise. Neurologic bladder is about that level of control, so if the lesion is above S2 to S4, so upper motor neuron lesion, you lose cortical inhibition but keep the reflexes, so the bladder becomes spastic. So small, hyperactive, you're going to be voiding a lot. If the lesion is at S2 to S4, a lower motor neuron lesion, so it's hitting those parasympathetics, you're not going to be able to void. So the bladder is going to be flaccid. So it can't contract, leading to an overflow incontinence. Uncal herniation is a compression problem. The uncus pushes downward and hits cranial nerve 3 first, causing a blown pupil on the same side, and at the same time, it compresses the corticospinal tract, giving contralateral weakness, big pupil, and opposite side weakness. That's going to be your uncal herniation. Tonsillar herniation is much more immediately life-threatening. The cerebellar tonsils herniate through that foramen magnum and compress the medulla, which houses the respiratory centers, and that's why the key clinical outcome is respiratory failure. And finally, posturing patterns tell you the lesion level relative to the red nucleus. So decorticate posturing means the lesion is above the red nucleus, right? Your arms are up and in, so flexion dominates in the arms. Then you have decebrate posturing, which means the lesion is at or below the red nucleus, removing the flexor influence and leaving pure extension. So if the arms are extended, the lesion is lower, and that's worse. All right. Okay, and just keeping going with these clinical correlations, just high yield stroke patterns, right? So an ACA stroke hits that medial cortex, which corresponds to leg regions of the homunculus. I know we haven't talked about that guy in a minute, so just please review the homunculus, right? If you have an exam coming up, it's not going to be in this video, but I have it in week 1, all right? So go back, watch that. That's why we have the hallmark is that contralateral leg weakness and sensory loss. The medial frontal lobe is also involved in motivation and behavior, so patients often have personality changes and just kind of seem off. So if the question says can't move the leg and they're acting like abnormal, that's going to be your ACA. An MCA stroke is the opposite pattern, so it's going to hit that lateral cortex where the face and arm live, so you get contralateral face and arm weakness and sensory loss, often worse than the leg, because the MCA also supplies large portions of the cortex. So you start layering on cortical signs like language, vision, and attention deficits. If the left MCA, the dominant hemisphere, is involved, language is the giveaway. So depending on the exact region, you'll see Broca's aphasia, right? Broken speech, can't speak. Wernicke's aphasia, you can't understand. Or global aphasia, which is neither. It's everything. Everything's clapped. So any stroke question mentioning speech problems, that's immediately going to be your left MCA. If the right MCA, the non-dominant hemisphere, is affected, the issue isn't language, right? It's awareness, and patients ignore the left side of the world and even their own body, and that's going to be that contralateral hemi-neglect. So if the patient says the patient can't recognize their left arm, that's the right MCA until proven otherwise. Visual deficits with an MCA stroke come from those optic radiations, so partial damage gives quadrantenopia. I'm so sorry, I've been talking for so long. Classically, the pie in the sky, which will be that temporal lobe or Meyer's loop, or pie on the floor, which will be that parietal, or Baum's loop. And so a larger lesion can wipe out the entire pathway, giving contralateral homonymous hemianopia. If you compress all of this into a quick mental rule, right? So just remember ACA is leg and behavior, MCA is face, arm, and cortex, and then decide left versus right based on language versus neglect, and then add those visual findings if the STEM wants to kind of throw a little monkey wrench in there. Continuing with this victory lap of stuff, we're just going to keep on going with the internal capsule. So the internal capsule, again, is that basically the highway where all major motor and sensory fibers are tightly packed together, and that's why a small lesion here causes big problems. So unlike cortical strokes, which are messy and specific, internal capsule strokes are dense and uniform. All right, so the genu carries corticobulbar fibers, so it controls motor function of the face. If this area is hit, you'll see facial weakness, specifically upper motor neuron type. So you're going to get that lower face droop with forehead sparing. Okay, because remember, upper motor neuron lesions regarding facial movements, if they're upper, they're up there with the forehead, and they like the forehead, so they're going to spare it. The posterior limb is a heavy hitter because it contains that corticospinal, which is motor to the body, and the thalamocortical sensory fibers. And when this gets knocked out, you lose contralateral motor and sensory function of the body. Everything goes at once because everything is packed together. And then you have the retrolenticular portion, which carries optic radiation, so lesions here affect vision, typically contralateral visual field deficits. And now the high-yield clinical tie-in here, so lenticulostriate arteries from the MCA supply this region. So these are small, deep, stroke-prone vessels, especially in hypertension. So when they occlude, you get a lacrinar stroke, which classically is a pure motor stroke. So no cortical signs, no aphasia, no neglect, no visual cortex deficits, just clean contralateral weakness. So the pattern to recognize is sudden, dense contralateral weakness, and maybe a little bit of sensory loss, no cortical features, right? You want to be thinking internal capsule stuff. You want to be thinking lenticulostriate, and then you want to be thinking lacunar stroke. All right, and just again, tying in more lesions. So an ICA lesion, again, is essentially a proximal problem, so it wipes out flow to both the ACA and the MCA territories. So that means you don't get a clean pattern. You just get a mixed picture, right? So you're going to get face and arm issues from the MCA plus leg stuff from the ACA together. So on top of that, because the ophthalmic artery branches from the ICA, you can also get ipsilateral monocular blindness. So if you see one eye blind and then a big hemispheric deficit, that's probably the ICA. A PCA cortical lesion is almost purely visual because it supplies the occipital lobe. So the classic finding is that contralateral homonymous hemianopia. So no motor deficits, no major sensory loss, just vision. That's going to be your clue that you're probably going to be working with a PCA stroke of some kind. The high yield twist here is the left PCA special case, which will cause alexia without agraphia. Okay, that's huge. That will definitely show up on boards and exam. It's a weird one, so it gets tested a lot. So left PCA stroke, alexia without agraphia. So the patient can write but cannot read, even though they just wrote down whatever they wrote down. They can't read that. This happens because the visual cortex is disconnected from the language areas, often via the splenium. So if a question feels weirdly specific about reading versus writing, that should be your cue, right? When PCA hits deeper structures, specifically the thalamus, you switch from vision to sensation. You get contralateral sensory loss, and over time, patients can develop severe chronic pain syndromes like DeJourney-Rousey. If the stem mentions burning pain after stroke, you want to be thinking thalamus because of that PCA. So if both PCAs are involved, you essentially knock out both visual cortices, okay? This leads to cortical blindness. The eyes and pupils can be normal. They are technically seeing, but the brain is not processing any of the visual input. So patients may even deny that they're blind, okay? But they truly are because their brain just can't process any of the information that is going to it. Okay, and now we are going to shift into just some clinical stuff, right? And so, we're just going to apply the same brain ideas to just behavior stuff. So addiction is best understood as a loop, not a single event. So the brain cycles through 3 phases, and each phase is dominated by a different circuit. In the binge intoxication phase, the key pathway is the mesolimbic dopamine system, specifically the VTA projecting to the nucleus accumbens. And this is the reward hit. So dopamine spikes here signal salience and reinforcement, basically teaching the brain, this matters, do it again. Every addictive drug, regardless of class, converges on the system. In the withdrawal phase, the system flips, so dopamine drops and the extended amygdala takes over. And this is the stress negative emotion circuit. Instead of chasing pleasure, the person is now trying to escape discomfort, anxiety, irritability, dysphoria, and this is where addiction transforms from wanting to needing. In the craving phase, higher order brain regions come online. So the prefrontal cortex, hippocampus, and amygdala interact to create urges tied to memory and context. And this is why triggers like places, people, emotions can drive a relapse even after long periods of abstinence. So the prefrontal cortex is supposed to regulate behavior, but in addiction, its control is very much weakened. All drugs essentially manipulate dopamine just through different entry points. So cocaine blocks dopamine reuptake, so it accumulates in the synapse. Nicotine directly stimulates the VTA, increasing dopamine release. And opiates inhibit GABA interneurons, which normally suppress dopamine neurons. So removing that brake leads to increased dopamine, right? So alcohol is more diffuse and the one that we kind of care about the most. So increasing GABA and decreasing glutamate, but the net effect is still enhancing that dopaminergic signaling indirectly. A key concept tying this together is negative reinforcement driven by corticotropin releasing factor, or CRF, which you should remember from endo-repro. And it's early on because people use for positive reinforcement, right? Like it just feels good. Like they just want to try it once. Later, they use it to relieve the withdrawal symptoms, so they feel less bad when they don't have it. And that shift is pleasure to relief, is what makes addiction so persistent and relapsing, right? You're no longer doing it for the funsies. You're doing it because you have to, because you don't want to feel bad. And if you compress the whole slide into just one idea, addiction starts as a dopamine-driven reward habit, but it persists because the brain rewires itself into stress avoidance loops that hijack decision-making. All right, so craving is not just wanting a drug, right? It's a coordinated brain state where memory, emotion, and decision-making converge to push a behavior. The prefrontal cortex is supposed to exert control, but in addiction, its regulatory function is weakened. So the hippocampus provides context, where you were, who you were with, while the amygdala attaches emotional weight to the cues. Together, they make previously neutral stimuli feel urgent and meaningful. And that's why relapse is often triggered by environments or stress rather than the drug itself. Allostasis explains why this doesn't reset easily. The brain shifts its baseline, so stress symptoms become chronically overactive while the reward systems become less sensitive. The result is that normal life just feels flat and stress feels way amplified. So the new normal is a dependent state where the person needs a substance just to feel baseline. At that point, use is no longer about getting high, it's about correcting a deficit, right? Alcohol fits cleanly into this framework because of its effects on inhibitory and excitatory balance. Acutely, alcohol increases GABA signaling and suppresses glutamate, which slows neural activity and produces sedation. Over time, the brain compensates by downregulating inhibition and upregulating excitation. When alcohol is removed, that compensation is unmasked. Now there's too little inhibition and too much excitation. The CNS becomes hyperexcitable, which is why withdrawal presents with tremors, agitation, and in severe cases, seizures. It's not just absence of alcohol, it's a rebound state where the system overshoots in the complete opposite direction. All right, so the circadian rhythm is the brain's internal 24-hour timing system, coordinating sleep, hormones, temperature, and metabolism into a predictable cycle. The control center for this system is the suprachiasmatic nucleus, or the SCN, in the hypothalamus. Think of the SCN as the body's master clock. It doesn't just track time, it synchronizes every other system to that time. So if the SCN is damaged, the rhythm doesn't just shift, it becomes disorganized or lost entirely. The SCN stays aligned with the outside world primarily through light input, and this comes via the retinohypothalamic tract, which carries direct signals from specialized retinal cells that detect ambient light, which is just not vision per se, just brightness. And there's also input from the geniculohypothalamic tract, which helps moderate and fine-tune this timing signal. Once the SCN processes this information, it sends output that regulate downstream systems. So one major target is the pineal gland, which secretes melatonin. And melatonin rises in darkness and promotes sleep, especially acting as the hormonal signal for night. The SCN also influences arousal systems, including projections that affect the raphe nuclei, helping regulate vigilance and wakefulness. So the key concept is that circadian rhythm is not just about sleep, it's a global timing signal that allows internal physiology with external that aligns internal physiology with external light and dark cycles. So when that alignment breaks via jet lag, shift work, SCN dysfunction, multiple systems, not just sleep, become incredibly dysregulated. All right, so sleep architecture is about cycling between two fundamentally different brain states, each doing a different job. So NREM, sleep progresses from light to deep, with stage 3 being the deepest and most restorative. So as you move deeper, the body shifts into a parasympathetic dominant state. Heart rate and respiratory rate drop, and overall metabolic demand decreases. Stage 2 is the most commonly tested because of its EEG features. So you're going to see sleep spindles and K complexes. Functionally, NREM, especially deeper stages, is tied to declarative memory consolidation. And physical restoration. Okay, so get your sleep, right? If you want to do well on tests, make sure you're getting good sleep because your brain does learning for you, okay? REM sleep is almost the opposite. So the brain becomes highly active while the body is effectively shut down through muscle paralysis. That's why it's called paradoxical sleep. EEG looks super awake, but the person is not. This is a stage of vivid dreaming, and it's heavily involved in procedural memory, so skills like motor learning and emotional processing. The paralysis is protective. Without it, people would physically act out their dreams. And I mean, maybe that's cool for some dreams, but I can think of a category of dreams, but that's not probably the best. Across the night, you cycle between NREM and REM multiple times, with more deep NREM early and more REM later. That structure matters. Disrupting it impairs both types of memory and overall recovery. So beyond memory, sleep serves several systemic roles, right? It conserves energy, supports immune function, and allows the brain to clear metabolic waste via something called the glymphatic system. And I've actually been waiting to talk about this because this is actually a new term. I'd say it's relatively new. I think I want to say like past 5 years, maybe 10. I don't. It's pretty recent though, and it's basically a lymphatic system for your brain. And the reason it's called the glymphatic system is because of glial cells. Okay, it's just a fun little term. I mean, I wouldn't worry about it, but I wanted an excuse to include it because I thought it was cool. So the glymphatic system, okay? And so the key takeaway is that sleep is not just a passive downtime, right? It's active, right? It's an organized process where the different stages handle different aspects of the brain and body maintenance. All right, so wakefulness is not one system. It's a coordinated network of monominergic nuclei plus a stabilizer, which is orexin, and that keeps you in the on state. So the monoamines are like serotonin from the Raphe nuclei, norepinephrine from the locus coeruleus, or dopamine from the ventral PAG region, and histamine from the tuberomammillary nucleus. And collectively, they drive cortical activation and alertness. So when these systems are firing, the cortex stays engaged and responsive. When they quiet down, they drift towards sleep. A key high-yield point is that these neurons are essentially silent during REM, which is why REM resembles a different brain state rather than just deep sleep, okay? Orexin, produced in the lateral hypothalamus, acts like a stabilizer for the entire system. It keeps the monoamine system active and prevents sudden transitions into sleep, so especially in REM. Without orexin, the system becomes unstable, and this is exactly what happens with something like narcolepsy, where patients just abruptly switch between wakefulness and REM-like states. So mental model is monoamines turn the lights on, and orexin basically just keeps them on. Sleep initiation is essentially an active shutdown process and not just turning off the brain, right? So the ventrolateral preoptic nucleus, or the VLPO, in the hypothalamus is the key player here. And it uses inhibitory neurotransmitters, primarily GABA and galanin, to suppress the wake-promoting monoamine systems, which come from the Raphe nucleus, the locus coeruleus, and the TMN, which we just talked about. So when the VLPO fires, it actively silences those arousal centers, allowing the brain to transition into sleep. And this sets up a kind of flip-flop switch, where either the wake systems are on or the sleep system is on, but not both at full strength simultaneously. Narcolepsy highlights what happens when the system loses stability. So the core issue is the loss of orexin neurons in the lateral hypothalamus. And since orexin normally stabilizes wakefulness by keeping arousal systems active, its loss leads to unstable boundaries between wake and REM. So patients don't just get sleepy, they just intrude into REM-like states while awake. So that's why you see phenomena like vivid dreaming during wakefulness, and sudden loss of muscle tone, which reflect REM-like atonia occurring inappropriately. So the key idea is not just, oh, I'm too sleepy, but it's just really bad REM regulation with state instability. All right, so consciousness comes down to two components: wakefulness, which is arousal, and awareness, which is content. And you need both. So wakefulness is driven by the brainstem reticular activating system, or RAS, projecting upward through the thalamus to the cortex, while awareness depends on intact cortical network processing information. The RAS is the key on switch, okay? It originates in the brainstem and sends diffuse activating signals to the thalamus and cortex, keeping you alert and filtering sensory input to the brain, filtering sensory input so the brain isn't overwhelmed. Okay, so if the RAS is knocked out, the cortex never gets activated, so no wakefulness and no consciousness. That's why the cause of a coma follows a pretty simple pattern here. You either destroy RAS itself with a brainstem lesion, or you disconnect the cortex on a large scale, which is classically like a bilateral cortical damage or bilateral thalamic damage. And unilateral lesions usually don't cause a coma because the other side can be compensated. A coma is the absence of both wakefulness and awareness, so no eye opening, no meaningful response. A vegetative state is different, right? So the sleep-wake cycle returns, so eyes are open, cycle is present, but there's still no awareness, okay? A minimally conscious state sits kind of in an in-between area where there are inconsistent but definite signs of awareness. Brain death is exactly what it sounds like. It just reflects irreversible loss of brain activity, including the brainstem. No RAS, no reflexes, no possibility of recovery. It's exactly what it sounds like. So the tricky part on exams is going to be recognizing what is not a coma. So in abula, the patient is awake but slow to initiate responses. In akinetic mutism, they're awake but they don't move or speak despite preserved awareness. In catatonia, the issue is psychiatric or motor, not loss of consciousness. So the key distinction is that all of these, the RAS is intact, the patient is awake, even if they appear unresponsive. All right, now we're moving on to pain. So pain isn't just a symptom, right? It's a protective signal the body uses to prevent further damage. So when pain is absent, patients accumulate injuries because there's no feedback telling them to stop or to protect damaged areas. And that's why congenital insensitivity to pain leads to repeated trauma and poor healing. So the detectors for pain are nociceptors, which are simple free nerve endings rather than specialized receptors. They are non-adapting, meaning they keep firing as long as the stimulus is present, and this is critical for survival because the signal doesn't fade if the danger persists. At the cellular level, they rely on ion channels that allow sodium influx, leading to depolarization. And these receptors respond to three main stimuli: mechanical, which is pressure and injury; thermal, which is extreme heat or cold; and chemical, which is inflammatory mediators released during tissue damage. With ongoing injury, the system becomes more sensitive, a process called sensitization or hyperalgesia. The activation threshold of nociceptors drop, so stimuli that were previously tolerable now produce pain, and this is driven by local inflammatory mediators such as bradykinin, prostaglandins, histamine, and increased extracellular potassium. At the same time, nociceptor fibers release neuropeptides like substance P and CGRP, which amplify inflammation and pain signaling locally. Pain transmission itself occurs along two main fiber types with distinct properties. You have alpha delta fibers, which are myelinated and conduct signals very quickly, producing sharp, well-localized first pain, typically superficial and pricking quality. In contrast, C fibers are unmyelinated and slower, producing dull, burning, poorly localized second pain, often deeper and more diffuse. This dual system explains why pain often starts sharp and then lingers as an ache. Overall, the pain system is designed not just to detect injury, but to amplify and sustain awareness of it, right? So it ensures that the behavior changes to promote protection and healing. All right, so all pain signals enter the spinal cord and synapse in the posterior dorsal horn, which is the first major processing station for nociception. This is not just a relay, it's an integration hub where pain can be amplified, dampened, or even modulated by other sensory inputs. At the synapse, primary afferent fibers release glutamate for fast signaling through AMPA and NMDA receptors, along with slower modulators like substance P, which is NK1 receptors, and CGRP, which prolong and intensify the response. Think of glutamate as that quick alert, while substance P and CGRP turn that alert into a sustained alarm. The second order neurons in the dorsal horn fall under two major functional types. You have nociceptive specific, NS neurons, which respond only to painful stimuli, giving you a clean, dedicated pain signal. And in contrast, you have wide dynamic range, or WDR neurons, which respond to both alpha delta and C fibers, and touch fibers, which are alpha beta fibers. And this is where things get clinically interesting. WDR neurons essentially compare inputs and encode the intensities of the stimulus. Because WDR neurons receive both touch and pain input, this is the anatomical basis for why rubbing an injured area can reduce pain. Non-painful alpha-beta input competes with nociceptive signaling at the same neuron. So it's not magic, it's literally the spinal cord level just competing against itself. So with repeated or high-frequency C fiber activation, you get a phenomena called wind-up, where WDR neurons become progressively more excitable. Mechanistically, glutamate initially activates AMPA receptors to depolarize the neuron. This removes the magnesium block from the NMDA receptor, allowing calcium influx, which strengthens and prolongs depolarization. Substance P further extends the signal, and CGRP enhances NMDA receptor activity, and the result is a sensitized neuron that over-responds to input, contributing to hyperalgesia and chronic pain states. So the bottom line is that the posterior horn is not just a checkpoint, right? It's where pain is interpreted, amplified, and modulated before it even reaches the brain. So gate control theory is essentially the spinal cord acting like a volume knob for pain, specifically in the posterior horn. The key idea is that pain signals are not just passively transmitted, they are actively regulated based on competing inputs and descending brain control. At the local level, touch and pain compete. Large, fast alpha-beta fibers, which are that touch, activate inhibitory interneurons in the dorsal horn, which suppress transmission from pain pathways. So in contrast, alpha-delta and C fibers, for pain, do the opposite. They inhibit those same interneurons, removing the brake and allowing pain signals to pass through more strongly. So the system is constantly balancing. Touch tries to close the gate and pain tries to open it. So that's why a simple clinical behavior like rubbing an injury reduces pain. You're activating alpha-beta fibers, which strengthen inhibitory interneurons and dampen nociceptive transmission before it even ascends to the brain. On top of the local gating, the brain exerts descending control. The para-aqueductal gray in the midbrain initiates modulation signals that travel down to the spinal cord. These signals pass through structures like the locus coeruleus, which releasing norepinephrine, and the raphe nuclei, which release serotonin. And norepinephrine is primarily inhibitory, while serotonin can either inhibit or facilitate pain depending on the receptor context. So this is why pain perception is highly state dependent. Functionally, this descending system explains real-world phenomena. So under stress or high adrenaline situations, the brain can suppress pain, right? Effectively closing the gate despite injury. You try to push through it. In contrast, during inflammation or chronic injury, the system can amplify pain, keeping the gate open and contributing to that hypersensitivity with that constant depolarization. Finally, pain processing operates in loops. Ascending pathways carry information from the spinal cord to the brain, okay? So that's going to go spinal cord, brainstem, thalamus, cortex, while descending pathways send modulatory signals back down. So that's going to go cortex, brainstem, spinal cord. So pain is therefore not a one-way signal, right? It's constantly adjusted, and it's a feedback mechanism. Okay, so the endogenous opioid system is the body's built-in pain suppression network, layered on top of gate control and descending modulation systems you just saw. So it uses three main receptor types: mu, delta, and kappa. It's the only time Greek life is going to help you in STEM. Just kidding. So which are activated by endogenous ligands like endorphins, enkephalins, and dynorphins. These receptors are G protein coupled and are strategically placed along the entire pain pathway from peripheral nociceptors to the spinal cord and brainstem. At the cellular level, the mechanism is straightforward but powerful. Opioid signaling decreases calcium influx into the presynaptic neurons and increases potassium efflux from the postsynaptic neurons. And this combination hyperpolarizes the neuron and makes it much harder to fire. Functionally, this means less neurotransmitters release, and particularly that's going to be glutamate and substance P, so the pain signal is weakened right at the synapse. Enkephalins are especially important in the dorsal horn, where they act like biological mute buttons. By shutting down alpha, delta, and C fiber transmission, they directly suppress incoming pain before it ascends. And this is essentially the chemical version of closing the gate, but more potent and lasts longer. What makes opioids clinically effective is that they act at multiple levels simultaneously. Peripherally, they reduce nociceptive activation, especially in inflamed tissue where receptor activation increases. In the spinal cord, they inhibit synaptic transmission in the posterior horn, and in the brainstem, particularly in the para-aqueductal gray, they enhance descending inhibitory pathways that further suppress pain signals traveling upward. So the key takeaway is that opioids don't just block pain in one spot, they stack inhibition across the entire pathway, which is why they're so effective and also why their effects are so widespread. All right, so all nociceptive information ascends through the anterolateral system, which is the main highway for pain, temperature, and crude touch. The pathway begins at the peripheral nociceptors, enters the spinal cord, and synapses in the posterior horn. From there, second-order neurons cross very early and ascend to the thalamus, which then relays the signal to the cortex. A key point is that the system is not just a straightforward line upward. Along the way, it sends collaterals to the brainstem, which feed into the descending modulation systems like the periaqueductal gray. So even though as pain ascends, it also is simultaneously being regulated. Within the spinal thalamic system, pain is split into two functional streams, right? We have that lateral discriminative pathway, which carries precise details of pain, where it is, how intense it is, and what it feels like. And this information is relayed through the VPL and VPM nuclei of the thalamus to the primary somatosensory cortex, giving you the ability to localize and describe the pain. In contrast, the medial or affective pathway handles the emotional and behavioral side of the pain. Instead of projecting to the primary sensory cortex, it targets regions like the anterior cingulate cortex, the insula, the amygdala, and the hypothalamus. These areas generate the unpleasantness, the urge to react, and the memory associated with pain. This is why pain isn't just a sensation, right? It's a whole emotional experience, okay? The critical takeaway is that pain has those two parallel circuits. One tells you what and where, and the other one tells you how much that pain should matter to you. All right, so remember, right, pain is not processed by a single center. It's distributed across multiple brain regions that each add a different layer to that experience. So the anterior cingulate cortex, or the ACC, is responsible for behavioral and emotional response to pain. It's what makes pain feel distressing and drives that reaction like withdrawal or avoidance. Notably, it activates not only with the real pain, but also with imagined or observed pain, which explains its role in empathy. The insula acts like a bridge between raw sensory input and the limbic system. It integrates the internal state of the body with the emotional context, helping encode the memory and subjective meaning of pain. And this is where pain becomes something you feel internally and not just to detect. And I remember that because the insula looks inside of you, right? The hypothalamus, in contrast, handles the autonomic and hormonal responses, things like increased heart rate, stress hormone releases, and the fight or flight reaction that accompanies painful stimuli. Beyond cortical processing, there are important ascending pathways that branch off early and shape how pain influences our behavior. So we have the spinomesencephalic tract, which projects to the periaqueductal gray and superior colliculus, and its primary role is to trigger descending pain inhibition, essentially recruiting the brain's internal analgesic system. At the same time, it helps orient attention and gaze towards the source of injury. So stimulation of the PAG, or the periaqueductal gray, can produce profound analgesia, okay, which is a key mechanism behind both endogenous opioids and opioid drugs, and analgesia being decreased pain, right? The spino-reticular tract projects to the reticular formation, locus coeruleus, and raphe nuclei. This pathway is less about identifying pain and more about arousal and attention. It ensures that pain wakes you up, captures your focus, and drives a motor response. And this is why even a mild painful stimuli can feel urgent. It's wired into the system that regulates alertness. So the overarching pattern is that pain is processed in parallel systems. One for perception, one for emotion, one for autonomic response, and one for arousal. And that's why pain is never just a sensation. It's a full body, multi-system event. All right, and just doing a little bit of a high yield on the nuclei that we're talking about. So we have the raphe nuclei, which are midline chain of brainstem nuclei that provide the brain's main source of serotonin. And their role in pain is primarily modulatory rather than sensory. They don't detect pain, they control how much pain gets through. So the rostral raphe projects upward towards the brain and are more involved in mood and emotional regulation, while the caudal raphe project downward into the spinal cord, where it directly influences dorsal horn neurons. In the context of pain, the raphe nuclei are a key component of the descending inhibitory system. So signals from higher centers, like the cortex and PAG, activate the raphe, which then sends serotonergic projections down to the posterior horn. There, the serotonin can suppress nociceptive transmission, often by activating inhibitory interneurons or enhancing endogenous opioid activity. And this is one of the main biological mechanisms behind top-down pain control. Running alongside this is the paleospinothalamic tract, which represents the older, more primitive pain pathway. Unlike this precise, fast lateral system, this pathway is diffuse and very poorly localized. Okay, so it projects to the intralaminar nuclei of the thalamus and broadly into the limbic system rather than to the primary sensory cortex. So as a result, it carries the emotional, arousal, and motivational components of pain rather than the exact location and intensity. Clinically, this is the pathway responsible for the kind of pain patients describe as dull, aching, or lingering, where they can't quite point to a specific spot. It also explains why chronic pain is so tied to mood and attention. The system feeds directly into circuits for emotion and alertness. So the key distinction is that neospinothalamic, or the lateral system, tells you where and what, while the paleospinothalamic system tells you how it feels and how much it matters, with the raphe nuclei acting as a major regulator of how strongly that signal is going to be expressed. And so finally, we have chronic pain. And it's not just pain that lasts longer, right? It represents a fundamental rewiring of the nervous system. Early on, pain is driven by actual tissue injury and nociceptor activation. But over time, the system itself becomes the problem. And this is why patients can have severe pain and even when the original injury has been healed. So clinically, this shows up as hyperalgesia, exaggerated responses to painful stimuli, or allodynia, which is pain from normally non-painful stimuli like light touch, and even spontaneous pain with no clear trigger. And these features tell you that the issue is no longer just peripheral, it's central. So the core mechanism is central sensitization, where neurons in the spinal cord and brain become hyperexcitable. Repeated inputs from alpha, delta, and C fibers, especially through mechanisms like wind-up, lower activation thresholds, and strengthen synaptic connections. So glial cells become activated, new synapses form, and receptor profiles shift, particularly NMDA-related changes. So the system essentially learns pain, and once that learning is established, it can persist independently of original injury. So over time, the pathway broadens. Pain signals move through the posterior horn and ascend via the spinothalamic, spinoreticularis, and spinomesencephalic tract to the thalamus and cortex, but they also increasingly engage the limbic system, reinforcing emotional and memory components. At the same time, descending modulation systems, like those from the periaqueductal gray and raphe nuclei, can become dysregulated, sometimes failing to inhibit pain or even facilitating it. So this progression explains the timeline. So initial pain is driven by nociceptors and inflammation, but chronic pain is driven by central changes that no longer depend on ongoing damage. At that point, pain is less of a signal of injury and more of a maladaptive state of the nervous system. And so finally, that brings us to the end of Neuro. Thank you all for sticking with me through Neuro. This was a beast. This is going to be probably the longest thing ever posted on this YouTube channel. I plan to do MSK either over the summer, just eventually. It will show up, and I assume MSK will get semi-close. I apologize for the lack of funny images. A lot of Neuro is just know the anatomy and then just kind of go from there. I tried to keep it pretty serious for a lot of this stuff just because Neuro's not something you want to be missing the anatomy on, because if you know the anatomy, a lot of it can kind of fall into place. So I know this wasn't, the usual goofy system as MooseMed has been known to be doing, but I hope this was incredibly useful for just having a bunch of information in one place. I hope you're able to use this as a way to, fix up whatever studying habit you're doing right now and spot things you missed on your first pass, whatever it may be. Regardless, thanks for being here with me. It's been a pleasure. This will probably be my last video for a while. So I'm not done, but I'm definitely going to be taking a break. So thank you guys. As always, thanks for stopping by MooseMed, where we take medicine by the horns, but for all intensive purposes, moose have antlers. Thank you all so much. I'll see you all when I see you. Good luck on exams. Good luck with studying. Kick Neuro in the ass. I believe in you. Peace.